Good evening all. For the next 15 minutes, we are going to discuss the important topics, important points related to the tongue and nose. Okay. So try to answer this image-based question. So in this image, you are seeing the patient is asked to protrude the tongue. Okay. So, and you are able to see the tongue is deviating towards right side, isn't it? The tongue is deviating towards right side, isn't it? So, which nerve is injured or paralyzed in this condition, in this patient? That is the question. Okay. So, deviation of tongue, okay, deviation of tongue towards right side is due to paralysis or injury of which of the following nerve? That's the question. Any idea? Yes, the answer is right hypoglossal nerve. Okay. So the point is, if there is injury of the hypoglossal nerve of one side, okay, the tongue will be deviating to the same side. Okay. We will be discussing in detail, okay, regarding this shortly. Okay. So that is the thing. The concept is, if there is injury to the hypoglossal nerve of one side, okay, the tongue will be deviating to the same side, that is affected side. Okay, that's the point. So let's talk about the various muscles of the tongue. Okay, this diagram is showing the 4 extrinsic muscles of the tongue. Okay, 4 extrinsic muscles of the tongue. So in this diagram, try to have the orientation anterior, posterior, superior, inferior. Okay, so this is the outline of the tongue, right? This is the tongue. Okay, so are you able to see one muscle is arising from the soft palate, and moving downwards to get inserted into the tongue, called as palatoglossus. Okay, then are you able to see one muscle is arising from the hyoid bone and moving upwards to get inserted into the tongue, called as hyoglossus. Okay, hyoglossus. Okay, and from the mandible bone, okay, from the mandible, specifically from the superior, this particular part is called the superior genial tubercle of mandible, where we have the origin of one muscle, namely genioglossus. Okay, this is the genioglossus muscle, and arising from the styloid process, one muscle is moving forwards to get inserted into the tongue, called as styloglossus. Okay, so these are the 4 extrinsic muscles of the tongue. What are they? Palatoglossus, from above, from below we have the hyoglossus, coming from front we have the genioglossus, coming from backwards we have the styloglossus. Okay, so according to the site of origin, these muscles are named as palatoglossus, hyoglossus, genioglossus, and styloglossus. Okay, so what will be the action of all these 4 extrinsic muscles of the tongue? Exactly, according to the site of origin only. Since the palatoglossus is coming from above, okay, the palatoglossus, when it contracts, it will cause elevation of the tongue. Okay, so remember, palatoglossus muscle causes elevation of tongue, upward movement of tongue. Okay, then what about the hyoglossus? It is coming from below, isn't it? So when this muscle contracts, it will move the tongue downwards, called as depression of tongue. Okay, depression of tongue. Okay, then genioglossus causes protrusion, that is forward movement of the tongue. Okay, protrusion of the tongue. This is the commonly asked question. Okay, which of the following muscle causes protrusion of the tongue? The answer is genioglossus. Okay, otherwise question may be genioglossus muscle causes which movement of the tongue? Answer is protrusion, forward movement. Okay, forward movement of tongue. Okay, fine. And obviously the styloglossus is arising behind and coming forwards. Origin is posteriorly. So when it contracts, it will move the tongue backwards, called as retraction of tongue. Retraction of tongue. Okay, so be clear. Okay, which muscle causes elevation, depression, protraction or protrusion, retraction of the tongue. Okay, fine. Now, let's talk about the important points about the genioglossus muscle. Okay, genioglossus muscle. Origin, as I told already, okay, it is arising from the superior genial tubercle of the mandible bone. Okay, and as you see here, it is getting inserted. This muscle is getting inserted into the entire tongue, entire length of the tongue. Okay, that's what mentioned. Starting from tip to the base of the tongue, from tip to the base of the tongue, entire tongue. Okay, and also some fibers are getting inserted into the hyoid bone also. Okay, so this is about the origin and the insertion of genioglossus muscle. Okay, other than origin insertion, you know the action of genioglossus, isn't it? It causes protrusion or protraction, that is forward movement of the tongue. Okay, it causes protrusion of the tongue. Okay, and the integrity of hypoglossal nerve. Okay, integrity of hypoglossal nerve is tested by which muscle? Exactly, genioglossus muscle. Okay, so genioglossus muscle is used for testing the hypoglossal nerve. Okay, tested by genioglossus muscle. That means what? Asking the patient to protrude the tongue. Okay, by asking the patient to protrude the tongue, you are testing the genioglossus muscle. That is indirectly you are testing the hypoglossal nerve. Okay, fine. And remember the one more important thing about the genioglossus muscle. This genioglossus muscle is also called as safety muscle of the tongue. Okay, genioglossus muscle is also called as safety muscle of tongue. What is the reason it is called as safety muscle of tongue? You will be knowing, isn't it? Because it causes forward movement of tongue, isn't it? That means we can say this genioglossus muscle, okay, prevents backward fall of tongue. It prevents backward fall of tongue. Okay, so what will happen if there is paralysis of genioglossus muscle? Yes, the tongue will move backwards. Okay, and it can cause airway obstruction. Okay, if genioglossus muscle is getting paralyzed, okay, it will result in airway obstruction because tongue will be moving backwards. Okay, so it may cause airway obstruction and it may cause even death because of the airway obstruction. That is the reason the genioglossus muscle is called as safety muscle of tongue. Okay, this question has been asked several times. Okay, so take care of this 3 or 4 important points about the genioglossus muscle. Fine. Okay, so as we discussed, the first slide we have seen one image based, okay, question, isn't it? So when both the genioglossus muscles, okay, when the right and left genioglossus muscles both are normal, both are intact, okay, when you ask the patient to protrude the tongue will be exactly moving in the midline. Okay, tongue will be okay protruded in the midline. Okay, there is no deviation of the tongue if genioglossus muscles are normal. Okay, but if there is paralysis of genioglossus muscle of one side of the tongue, for example, in this diagram, right side genioglossus muscle got paralyzed, isn't it? So when you ask the patient to protrude the tongue, you can clearly see the tongue is deviating towards the right side, that is affected side. Okay, that is the concept here we have to remember. Okay, so if there is right hypoglossal nerve, okay, if there is right hypoglossal nerve injury, obviously right genioglossus muscle will get paralyzed. So when you ask the patient to protrude the tongue, okay, tongue will be deviating towards which side? Right side, that is affected side. Okay, which side the muscle is getting paralyzed? The same side. Okay, so affected side, the tongue will be deviating. Okay, this is the point. Whatever side the muscle and the nerve are getting injured or paralyzed, same side, that is affected side, there will be deviation of the tongue. Is it fine? Okay. So that's what. So the answer for this question is identify the nerve injured. As you see in this diagram, the tongue is deviating towards right side, okay, during protrusion. So it is because of the injury and paralysis of right hypoglossal nerve and right genioglossus muscle. Fine. Okay. So now let's talk about the innervation or nerve supply of the tongue. Okay. When you talk about the nerve supply of tongue, motor innervation is by hypoglossal nerve. So all the tongue muscles are supplied by hypoglossal nerve except one muscle. Okay. Except which muscle? Yes, except palatoglossus, PG. Except palatoglossus. Palatoglossus is not supplied by hypoglossal nerve. Okay. So palatoglossus is supplied by cranial root of accessory nerve via vagus nerve. Okay. This is the point. All tongue muscles are supplied by hypoglossal nerve except PG, palatoglossus. Okay. Palatoglossus is supplied by cranial root of accessory nerve via vagus nerve. Okay. Fine. What about the sensory innervation of the tongue? Just now we have talked about the motor innervation, isn't it? Just now we have talked about motor innervation of the tongue. Coming to the sensory innervation, if you take the anterior 2/3 of the tongue, okay, from the anterior 2/3 of tongue, general sensations are carried by lingual nerve. General sensations from the anterior 2/3 of tongue carried by lingual nerve, and special or taste sensation from anterior 2/3 of tongue is carried by chorda tympani nerve. Okay. And I hope you will be knowing this lingual nerve is a branch of mandibular nerve. Okay. Lingual nerve is a branch of mandibular nerve. Okay. That is fifth cranial nerve. Branch of trigeminal nerve, fifth cranial nerve. Fine. Whereas chorda tympani nerve is a branch of facial nerve, seventh cranial nerve. Okay. Facial nerve is the seventh cranial nerve. Fine. Okay. What about the posterior 1/3 of the tongue? This green color is representing posterior 1/3 of tongue. From the posterior 1/3 of tongue, both general sensation and special sensations are carried by glossopharyngeal nerve. Glossopharyngeal nerve, ninth cranial nerve. Okay. Ninth cranial nerve. What about the posterior most part of the tongue? From the posterior most part of tongue, both general and taste sensations are carried by internal laryngeal nerve. Internal laryngeal nerve. Actually, it is a branch of 10th cranial nerve, that is vagus nerve. Okay. Branch of vagus nerve, that is 10th cranial nerve. Okay. Fine. So this is about the innervation of the tongue. Okay. Motor innervation and sensory innervation of the tongue. Okay. And are you able to see the largest papillae? The one I am marking now, called as circumvallate, or simply called as vallate papillae. Vallate papillae or circumvallate papillae. Okay. So from the circumvallate papillae, the sensations, taste sensations are carried by glossopharyngeal nerve. Okay. It is not by chorda tympani nerve or lingual nerve. From the circumvallate papillae, the taste sensations, okay, as well as general sensations are carried by glossopharyngeal nerve. Okay. Fine. So now let's talk about the important things related to the nose. Related to the nose. Okay. Actually, you are seeing the nasal septum. Okay. In this diagram. In this diagram, you are seeing the nasal septum. Okay. And I hope you will be having the orientation in this diagram, which is anterior, posterior, superior, and inferior, isn't it? So, as you see here, the antero-inferior part of nasal septum is called as Little's area. Okay. So, Little's area is the antero-inferior part of the nasal septum. Okay. What is the importance of the Little's area? Exactly. It is the site of rich arterial anastomosis, rich vascular supply or blood supply, that is rich arterial anastomosis, and that anastomosis is called as Kieselbach's plexus. Okay. Kieselbach's plexus is the arterial anastomosis formed at the so-called Little's area. Fine. So from this diagram, you can understand, okay, what are the four arteries taking part in the Kieselbach's plexus or Kieselbach's anastomosis at the Little's area. Yes, one is greater palatine artery, then sphenopalatine artery, then we have the anterior ethmoidal artery, then we have the superior labial branch of facial artery. So these are the four arteries taking part, okay, four arteries taking part in the Hasselbalch's plexus at the little's area, okay. This is a repeatedly asked question, okay. So what are the arteries taking part in the Hasselbalch's plexus at the little's area? Okay, you can remember the four arteries as gas, GASS, okay. What are these four arteries? Yes, greater palatine artery, G representing greater palatine artery. Then S is spinopalatine artery, spinopalatine artery. Then anterior ethmoidal artery, anterior ethmoidal artery. Then superior labial artery, superior labial artery, which is a branch of facial artery, okay. So usually in the exception, you will have posterior ethmoidal artery, okay. You will be having posterior ethmoidal artery. So remember, posterior ethmoidal artery is not taking part in Hasselbalch's plexus, okay. So GASS, four arteries, okay. And one more thing is, out of these four arteries taking part in Hasselbalch's plexus, the one more important question is, anterior ethmoidal artery is a branch of ophthalmic artery, okay. Anterior ethmoidal artery is a branch of ophthalmic artery, which in turn is a branch of internal carotid artery, ICA, internal carotid artery, fine. What about the other three arteries mentioned here? Yes, greater palatine, spinopalatine, both are branches of maxillary artery, which in turn is a branch of external carotid artery, okay. Fine. Greater palatine, spinopalatine, both are branches of maxillary artery, which are branches of the respective external carotid arteries, okay. Again, facial arteries, you will be knowing, facial artery is a branch of external carotid artery only. So the question previously asked, all the following, all the arteries taking part in the Hasselbalch's plexus are branches of external carotid artery except, what is the answer? Anterior ethmoidal artery. Anterior ethmoidal artery is a branch of ophthalmic artery, which in turn is a branch of internal carotid artery. The remaining three arteries are indirectly, they are branches of external carotid artery. Fine. Okay. Take care of this point. And one more thing is, you will be knowing the importance of Little's area, right? This is a common site of Little's area, is a common site of bleeding from the nose due to trauma, okay. Common site of bleeding from the nose called as epistaxis, okay. So what do you mean by epistaxis? Epistaxis means bleeding from the nose, nasal bleeding, okay. So common site of epistaxis is Little's area, okay. And the bleeding usually occurs due to damage mainly to the spinopalatine artery. That is the reason the spinopalatine artery is also called as artery of nasal bleeding, that is artery of epistaxis. So the bleeding from the nose is mainly because of injury to the spinopalatine artery, so it is also called as artery of epistaxis, right? Okay, now next 3 or 4 minutes, let's talk about the lateral wall of nose. This diagram is showing the lateral wall of nose, okay. So lateral wall of nose contains 3 bony projections, okay, called as superior concha, middle concha, inferior concha, okay. 3 bony projections from above downwards called as superior concha, middle concha, inferior concha, okay. So I hope you know the meaning of concha or concave. They are bony projections, okay. And just below the concave, we have some spaces called as meatus. So below the superior concha, we have superior meatus. Below the middle concha, we have middle meatus. Below the inferior concha, we have inferior meatus. Okay. So concave are bony projections. Okay. What about the meatuses? Yes, meatuses are spaces spaces or depressions below the corresponding concave. Okay. So, and do you see just above the superior concha, even above the superior concha, there is one depression, okay, called as sphenoethmoidal recess. Sphenoethmoidal recess, okay. And now we have to remember what are the various structures opening into the various meatuses of the nose, fine. So before that, I have told you there are three concha, right? Superior concha, middle concha, inferior concha. As you see here clearly, the inferior concha is the largest. Okay. So see this slide. Concha or bony projections. They are otherwise called as turbinates. Okay. And there are three concha: superior, middle concha, inferior concha. Okay. One important thing is superior and middle concha both are parts of ethmoid bone, whereas inferior concha is an independent bone. Okay, inferior concha is an independent or separate bone. Okay, this question has been asked already, and it is the largest concha. Inferior concha is the largest concha. Okay, fine. And now I told you just below the concha we have the meatuses, which are nothing but spaces, gaps or spaces. Okay, so we have superior meatus, we have middle meatus, we have inferior meatus. Okay, out of these three meatus, the largest meatus is inferior meatus. Okay, so inferior concha and inferior meatus are the largest, concha and meatus. Okay, so now other than these three meatuses, I told you something called a sphenoethmoidal recess, isn't it? It is a depression even above the superior concha, Fine. Okay. Now, the middle meatus, remember the two important features. One is called as bulla ethmoidalis, another one is called as hiatus semilunaris. Okay. Bulla ethmoidalis, bulla means elevation. Okay, so bulla ethmoidalis is a rounded elevation. Okay, it is a rounded elevation present in the middle meatus, and just below the bulla ethmoidalis we have one deep depression called as hiatus semilunaris. Okay, fine. So now in the next slide we are going to discuss what are the various structures opening into various meatuses. Okay, so see this diagram. This is the sphenoidal air sinuses. Okay, this is the sphenoid air sinus. Okay, so the sphenoid sinus opens into which structure? Yes, the sphenoid air sinus opens into the sphenoethmoidal recess. Okay, so sphenoidal air sinuses open into sphenoethmoidal recess. Okay, and posterior ethmoidal air sinuses open into superior meatus. You can remember in the superior you have the PE, the two letters. Okay, so posterior ethmoidal, PE, posterior ethmoidal air sinuses open into superior meatus. Remaining all the air sinuses other than sphenoidal and posterior ethmoidal, all the remaining air sinuses open into the middle meatus, either into the bulla ethmoidalis or into the hiatus semilunaris. So bulla ethmoidalis receives the opening of middle ethmoidal air sinuses. You can remember as BE, bulla ethmoidalis receives the opening of middle ethmoidal air sinuses. Okay, then remaining all frontal air sinus, anterior ethmoidal air sinuses, maxillary air sinus, all open into the hiatus semilunaris, Okay, and inferior meatus does not receive any openings of the paranasal sinuses, but it receives one important structure, okay, which drains the lacrimal secretion called as nasolacrimal duct. Okay, very commonly asked question. Nasolacrimal duct opens into which of the following meatus? The answer is inferior meatus of nose. Fine. Yes, this is the last slide. As we discussed, this is the superior concha, this is the middle concha, this is the inferior concha. Okay, below the concha we have the corresponding meatuses: superior meatus, middle meatus, inferior meatus. Okay, and I told you the two important features of the middle meatus. Okay, it contains one elevation called as bulla ethmoidalis. Okay, and below the bulla ethmoidalis, we have one deep depression within the middle meatus called as this one. Okay, called as hiatus semilunaris. Okay, this hole, hiatus semilunaris. Okay, okay, fine. So, and this is the sphenoethmoidal recess. This is the sphenoethmoidal recess, which receives the opening of sphenoidal air sinuses. Okay, then as you see here, superior meatus receives the opening of posterior ethmoidal air sinuses. Okay, and bulla ethmoidalis receives the opening of middle ethmoidal air sinuses. Okay, and hiatus semilunaris receives the openings of frontal air sinus, anterior ethmoidal air sinus, and maxillary air sinus. And finally, the inferior meatus of nose receives the opening of. So this is about the openings of the various structures in the lateral wall of nose. Openings present in the openings of various structures present in the lateral wall of the nose. Okay, fine. That's the end of today's session. Thank you all. Thank you.
Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Okay, so we will start off the class. Okay. So yesterday, just give me a second. So yesterday we were dealing with the lymphomas which arise from the germinal center, isn't it? So we have finished Hodgkin's lymphoma before, and then yesterday we went through all the general concepts and follicular lymphoma. And now today we are going to deal with two important topics, okay, two important NHLs which also arise from germinal center, and they are frequently asked in INICET and NEET PG. Okay, so that will be Burkitt's lymphoma and diffuse large B-cell lymphoma, DLBCL and Burkitt's lymphoma. So follicular lymphoma, Burkitt's, DLBCL and Hodgkin's arise from germinal center. First point, just to recapitulate. Second point is these four are from mature B cells. Okay, so important question, both are important question. So now we will quickly go into the concept of diffuse large B cell lymphoma. Okay, so it is the most common non-Hodgkin's lymphoma in India. Which is the most common Hodgkin's lymphoma in India? It's mixed cellularity. Most common non-Hodgkin's lymphoma in India is diffuse large B-cell lymphoma. Potential question. Next one, it arises from mature B-cell, that you know. Okay, it arises from mature B-cell. Okay, then what is the age group it is going to affect? It is going to affect older age groups. Okay, the median age is 60 years. The median age is 60 years. And the most important MCQ point is it has the worst prognosis amongst all the NHL. It has the worst prognosis amongst all the NHL. This is about the general introduction, the MCQ points, whichever I have mentioned. Okay. Next, coming to immunophenotyping. Okay, like in all NHLs, you have to remember this. General points 4 or 5, immunophenotyping, cytogenetics, and prognosis. That's all. Okay. So when coming to immunophenotyping, I already told you it is mature B cell. So of course, it has to be CD19 and CD20 positive always. Okay. This is one thing. Next one is because it is from the germinal center. One more point we have to remember is it can be from the germinal center or from the marginal zone. In the previous image I had shown you. So whenever it is from the germinal center, it will express CD10 and BCL6. Okay, because these are germinal center markers. Okay, and because they are from the mature B cells, they will have surface immunoglobulin. Surface immunoglobulin. So this is the immunophenotyping. You got it? This is the immunophenotyping. Nothing, simple, because it's B cell, CD19, CD20 positive. If it is germinal center, okay, it's CD10 and BCL6 positive. So variable positivity. This is variable positivity depending upon whether it is germinal center or activated B cell. That is too much for y'all. So that is why I didn't mention. So DLBCL can be either germinal center or activated B cell. So when it is activated B cell, this germinal center markers will be absent. But so you have to remember it as CD10 and BCL6 variable positivity. Surface immunoglobulin is positive. Fine. This is about the immunophenotyping. Now coming to cytogenetics. Yesterday, if you remember in the class, I told you follicular lymphoma can progress to diffuse large B-cell lymphoma, isn't it? So you have to remember around 30 to 35% can have translocation 14-18. 14 is IGH, 18 is BCL2. Okay. And then next, one more important translocation is BCL6 on chromosome number 3q27. On chromosome number 3, at least you have to remember. BCL6, which is present on chromosome number 3, at that loci, if there are mutations, it will lead to diffuse large B-cell lymphoma. And then next is MYC translocation. MYC translocation classically is associated with Burkitt's. It can also be seen in diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma, okay, the cytogenetics, it extends on that side to follicular lymphoma and on this side to Burkitt's lymphoma. And it also has the majority translocations in BCL6, which is there on chromosome number 3, okay, 3q27. Fine. And then next, coming to what are the other important points in diffuse large B-cell lymphoma? See, when it comes to diffuse large B-cell lymphoma, either it can be associated with immunodeficiency, especially T-cell immunodeficiency, okay, or it can be primary effusion type. See, one more important point you have to know in diffuse large B-cell lymphoma is it affects the extranodal tissues most commonly, non-Hodgkin. So it affects the extranodal. It diffuse large B-cell because it affects the extranodal tissues, especially CNS, okay, testis and other extranodal things, but especially when it is CNS, primary CNS, it is going to be diffuse large B-cell lymphoma, okay. That is one point you have to know. And apart from that, when it is immunodeficiency associated, I told you, whenever the patient is having, the patient can give you history of HIV, okay, or T-cell immunodeficiency, say for example, bone marrow transplant or solid organ transplant, where T-cell suppression is induced, okay. And the interesting point is restoration of T-cell immunity will regress diffuse large B-cell lymphoma, okay. So restoration of T-cell immunity will regress lymphoma. Okay, so this is regarding immunodeficiency. So in your history, if they have given a renal transplant patient or bone marrow transplant patient who is on immunomodulators, okay, where T-cell immunosuppression is there, or HIV patient, and that time you have to think of DLBCL, which is immunodeficiency variant, okay. Primary effusion, what is important is these, when it is primary effusion type of DLBCL, where it presents with pleural effusion or ascitic effusion, okay, when it presents with that, the patient will usually show latent infection with human herpes virus 8 or Kaposi sarcoma virus. That is one important thing. And then next one thing is they will lack both B cell and T cell. Only this variant will lack, it's a special variant, will lack both B cell and T cell markers. It will lack both T cell and B cell markers. Okay, so you have to remember the special type variants in diffuse large B-cell lymphoma when it is immunodeficiency associated or when it is primary effusion type. Right? And you have to remember that it is usually extranodal, especially CNS. Okay, fine. So how will it look on the histology? See, of course, the architecture of the lymph node will be effaced, so there will be no follicles, nothing. It will be homogeneous, okay? And see, you will see large cells, around 2 to 3 times the size of the normal small lymphocyte, okay? And they will have large nuclei with prominent nucleoli, scant cytoplasm, vesicular to hyperchromatic nuclei. The nuclear margins are irregular. So the cells are larger. What is the size? 2 to 3 times the size of lymphocyte. They will have scant cytoplasm. Okay, they will have increased NC ratio, and the nuclei will have irregular nuclear margins. Okay, there is no definite nuclear shape, and they will have 1 to 2 prominent nucleoli. Vesicular nucleus, that means empty looking to hyperchromatic nuclear. Okay, so when they give you this image, you all should be able to identify the image. Okay, image based question, diffuse large B cell lymphoma. Fine. So like yesterday, how I showed you in follicular, marginal zone and mantle zone, lymph node in spleen, what will happen? White pulp will be enlarged, isn't it? Like small nodules. But see, when it comes to diffuse large B cell lymphoma, it will appear like this. Lymphoma is always fleshy. So it will appear like a irregular mass in the spleen. Okay, irregular mass in the spleen. So you have to know that. Now I think you can remember the yesterday's picture and today's picture. Okay, so this is about the spleen in diffuse large B-cell lymphoma. This brings us to the end of diffuse large B-cell lymphoma. I have told you all the important points in diffuse large B-cell lymphoma. Okay, so now we will look at Burkitt's lymphoma. See, Burkitt's also arise from the germinal center. So it is mature B-cell. Okay, and here because it's mature B-cell, you know that it is going to be immunoglobulin positive. Okay, one important point there, how I told you it is the most common in India and worst prognosis. Here you have to remember it is very aggressive tumor, high mitotic activity, that means rapidly dividing, and this is the most common tumor associated with tumor lysis syndrome. All the three are important questions. Tumor lysis syndrome. Fine. This again can be three type. Okay, endemic, African. Okay, where the patient is small children or young adults presenting with mandible swelling. Okay, they all the cases, most of the cases are associated with EBV infection, Epstein-Barr virus infection. Endemic or African. Sporadic. This also affects young adults, but usually present with ileocecal mass. Okay, ileocecal mass or peritoneal mass. Next, the third variety is HIV associated. This is also associated with Epstein-Barr virus, latent infection with Epstein-Barr virus infection. Okay, this is one important thing. And when coming to immunophenotyping, because it is B-cell, isn't it? B-cell, so it will be CD19 positive, CD20 positive, mature B-cell, so immunoglobulin positive, and germinal center, so CD10 and BCL6 positive. One more thing important you have to remember to differentiate this from follicular is it is BCL2 negative. Diffuse large B-cell can be BCL2 positive when it is associated with translocation 14-18, but this is never associated with BCL2 positive. It is always BCL2 negative. Okay, when coming to cytogenetics, it is associated with c-MYC, MYC proto-oncogene mutation. Okay, this MYC proto-oncogene is present on chromosome number 8. Okay, so the translocations can be 8-14, where MYC with IGH, heavy chain, okay, translocation, or it can be 2-14, where 2 will have immunoglobulin light chain kappa. 2-8, sorry, it is not 2-14, it is 2-8. Okay, 2-8. 8-14, 2-8, or translocation 8-22. Okay, this is with immunoglobulin light chain lambda. Fine. How are the tumor cells going to look? Tumor cells are, see, high mitotic index. So mitotic figures will be very high. The tumor cells are 2 times the size of the lymph node. Okay, lymphocyte, and they have clumped chromatin. Okay, they have clumped chromatin. Okay, and they'll have prominent nucleoli. They will have prominent nucleoli. Okay, and the best part of this is they will have royal blue cytoplasm. They will have royal blue cytoplasm. They will have royal blue cytoplasm. Okay, and in that cytoplasm, they will have prominent vacuoles. They will have prominent vacuoles. Okay, they will have prominent vacuoles, cytoplasmic vacuoles. Fine. In the bone marrow, you will see similar type of cells. In the bone marrow, you will see similar type of cells. Fine. Okay, this is about Burkitt's lymphoma. When it comes to Burkitt's lymphoma, see, starry sky appearance, very classical. Starry sky appearance. You have to never forget that point. Why the starry sky appearance? Because I told you these cells are highly mitotically active, isn't it? They are very highly mitotically active, means they are undergoing fast division, and they undergo apoptosis also quickly. When they undergo apoptosis, to engulf these apoptotic cells, we need macrophages. So these macrophages will be there in between. Okay, so these macrophages have foamy cytoplasm and look empty when compared to the blue color tumor cells. So when these macrophages are dispersed in between the blue color tumor cells, they appear like starry sky. They give that starry sky appearance. Someone looked at it and they felt it's a starry sky, and so it is called starry sky. Okay, so you understood the logic behind it, because these cells, macrophages, are there in between this dark blue tumor cells. These macrophages are lighter staining, paler staining, because the cytoplasm is foamy. Okay, they give a starry sky appearance. Okay, so you have to remember starry sky appearance. Fine. Okay, so these are the important points regarding Burkitt's. Burkitt's starry sky image based question, important potential question. And then this is your spleen in case of diffuse large B cell lymphoma. Okay, and this is the image for diffuse large B cell lymphoma, very large cells. Okay, very large cells. Okay, so see here, so we are done with germinal center lymphomas. Follicular, Burkitt's, diffuse large B cell, and Hodgkin. So you have no doubt. So they all have in common what? CD19 positive, CD20 positive, CD10 positive, and BCL6 positivity. Follicular has special BCL2 positivity. Burkitt's has NIC positivity. Okay, and diffuse large B cell lymphoma, BCL6 itself, mutation can occur in chromosome number 3. Hodgkin's is a different entity. So tomorrow we'll look into marginal zone lymphoma, okay, and mantle cell lymphoma. So they are those special types, okay, when coming to the things. After that, we'll finish off with CLL, SLL. Okay, fine. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Good evening, students. We'll discuss a few important topics in mycology. We'll start with dermatophytes. Derm, as you know, derm is your skin. So the fungus infection of skin, hair, and nail is called by dermatophytes. And that the disease is called dermatophytosis. The other name for dermatophytosis is tinea or ringworm infection. So you can get ringworm infection is nothing. It's dermatophytosis. Okay, why we say ringworm? That we'll see the picture. So it affects both skin, hair, and nail. So please remember, it infects skin, hair, and nail, and they are keratinophilic fungi. So all keratinized tissue will be getting infected with dermatophytes. Okay. So we have three etiological agents which causes dermatophytosis. That is your microsporum, epidermophyton, and trichophyton. Okay, microsporum, epidermatophyton, and trichophyton. So we'll just remember, microsporum does not causes nail infection. Okay, so it will never cause nail infection. Only cause skin and hair infection. Trichophyton can infect all skin, hair, and nail. So all three infections is caused by trichophyton. Epidermatophyton will infect only skin and nail. It will never infect hair. So how to remember this? As just remember, M and N does not go together. So microsporum will never cause nail infection. And you just remember he, H and E. So hair infection is never caused by epidermatophyton. Okay, which causes all three infection is your trichophyton. So this has been asked in various entrances. It has been asked in NEET 2012 also. Which causes all three infection is your trichophyton. So how we classify? This was the etiological agent. Now coming to ecological classification. So they are anthrophilic, zoophilic, and geophilic. Okay. So which are anthropophilic? Okay. So your tinea, mentagrophytes, rubrum, violaceums, microsporum audoni, ferruginum, flocosum. These are anthropophilic. Which are zoophilic? Okay. So your equinum, verrucosum, microsporum canis, microsporum equinum. So these are your zoophilic. Okay. So it has been asked which of the following is zoophilic dermatophytes except. So you should be remembering which are anthropophilic, which are zoophilic, which are zeophilic. So your trichophyton azole, terrestri, amazonic, microsporum amazonicum, epidermophytum stockdale, these all are geophilic. So we read three: anthropophilic, zoophilic, and zeophilic. So and zoophilic has been asked plenty of times. So you just remember trichophytum equinum, verrucosum, microsporum canis, microsporum equinum. These are zoophilic dermatophytes. Now the dermatophytes, as we read, like it is the commonly known as tinea, or we say it as a ringworm infection because we say in a ring like picture. Okay, central clearing will be there, so we say ringworm infection. So ringworm, patch with inflammatory border and central clearing with scale. So you can see, okay, ringworm infection, you will have inflammatory border and central clearing will be there. Okay. Ringworm infection and onycho is your nail. So nail infection, the term is used onychomycosis. So that is also caused by tinea. So depending on body part, what all infection tinea causes. So if it is capitis, you can see the picture. Capitis is your head infection, scalp infection. Okay. So facie is your facial infection. Barberry is beard infection. Corporis is your body infection, which is commonly we say corporis word is we use for ringworm infection. Okay. Manum is your hand infection. Angwam is your nail infection. Cruris is your which also call it jock itch, is your perineal infection, perineum region infection. Pedis is also called as athlete foot, that is your foot infection. So there are few terms. Scalp ringworm, we say Tinea capitis. Ringworm commonly we use for Tinea corporis. Then cruris is also called as jock itch, which we use for perineum region infection. And pedis, also called athlete foot. So this is your foot infection. Mainly this happens in the people who are having more sweating, exposed to heat. So athlete, they will be always in the shoes. So they will be sweating in the foot. So that is called athlete foot. Okay. Now coming to favors. What is favors? This also NEET, you got a question, favors. So Tinea fabosa, okay, which is caused by Trichophyton schonleni, okay. So how you see crust, okay, which infects the hair follicle, and fungal will grow within hair, okay, and patchy alopecia you can see, and it will heal with scarring. So that is your favors. Favors is nothing. A severe form of Tinea capitis, which is caused by Trichophyton schonleni, which has been asked previously. Favors is caused by, so you see scarring alopecia. So apart from mycology, you can get the question in dermatology also, similar kind presentation. What is black dot? Black dot is caused by Trichophyton tonsurens or violaceums. So in this endothrix, ectothrix is hair shaft which is seen outside, which goes inside, we say it as a endothrix. So endothrix invasion will be there, and breakage will be there near the surface, which result in a black dot formation. So we say it as black dot. Okay. So this also causative agent has been asked. Please remember Trichophyton tonsurens and violaceum. Okay, it causes black dot. So these all are scalp infection. So we read favors and black dot. Okay. So what is carrion? Carrion is nothing but painful, inflammatory, boggy mass lesions which breaks the hair follicle. Okay. The untreated Tinea capitis progress to carrion. So we'll see the dermatophytes tinea, what all. So you get the gray patches. This is caused by Microsporum odoni mainly. You can see the patches there. Black dot, okay, which brittle hair shaft break at the level of scalp. So the lower part of hair stays. So that gives a black dot appearance, which is caused by verrucosum and mentagrophytes. Okay. Carrion, we saw boggy swelling, right? The term when you get the boggy swelling, your clue is towards carrion, okay? Tonsurens, violaceum, favors, yellow cup-like crust we see, okay? So what is ectothrix and endothrix? When the spore formation occurs in the shaft surrounding, endothrix inside the hair shaft. Okay, so if it is inside the hair shaft, we say it as a endothrix. When outside, we say it as a ectothrix. So this will be endothrix. This will be your ectothrix. Okay, so two type of hair infection is mainly. So which all causes ectothrix? So Microsporum odoni, Microsporum canis, Trichophyton mentagrophytes causes ectothrix. So which has been asked recently in your NEET entrance. Options were Microsporum odoni was the answer. So please remember Microsporum odoni, canis and Trichophyton mentagrophytes. So endothrix is caused by Trichophyton tonsurens, violaceum. Okay, so we can see macroconidia and microconidia. Macroconidia will be abundant in your epidermatophyton, which will be rare in trichophyton. Microconidia will be abundant in trichophyton and rare in epidermatophyton. This has not been asked previously, but it can be a probable exam question. Which are urease positive? Yes, it has been asked. Trichophyton, mentagrophytes will show urease test positive. So this pink color change indicates urease positive. Hair perforation test. This year also in the NEET you got hair perforation test. Hair perforation test pierce the hair producing wedge-shaped perforation. You can see this is the hair perforation test. Okay, here there is no hair perforation, so this is negative. This is hair perforation test positive. So where we see hair perforation test positive, we see in trichophyton, mentagrophyte, and microsporum canis, which shows hair perforation test negative. Okay, so this has been asked previously. Trichophyton, mentagrophyte, and microsporum canis shows hair perforation. This year also NEET you got something related to hair perforation test. So please remember these two species. How we treat. There is, you have topical treatment, you have oral treatment. When you are treating the nail and infection, the treatment goes for months and years. Okay, for tinea capitis, we have topical application, topical shampoos are there. Selenium sulfide shampoo, which has been asked previously, which shampoo we use for tinea capitis. Coming to Cryptococcus. Cryptococcus we have discussed, right? Plenty of time. It's encapsulated yeast. The capsule is polysaccharide in nature, and it is opportunistic pathogen. In the classification of fungus we read, it infects mainly lung and CNS apart from other organs. So this has been asked plenty of time. Which are the organ which is affected by Cryptococcus? So your answer should be CNS and lung. As we have seen the infection, we see in HIV positive and immunocompromised patient, Cryptococcus is more common. So it's a true yeast. We saw in a classification, it has a capsule. So how you demonstrate the capsule? Please remember India ink and nigrosine. This has been asked plenty of time. How you demonstrate the capsule of Cryptococcus. Okay. And apart from that, PAS and mucicarmine staining also can be done. So what is the serological latex agglutination test we do for antigen detection for Cryptococcus? And we can culture them in Sabrot, Strextrot, agar, right? So this also has been asked, latex agglutination test. Coming to Candida, there are various species of Candida. Candida is one of the invasive fungal infection mainly seen in immunocompromised patients. So we have albicans, tropicalis, cruzi, Lusitani. So please remember, cruzi shows fluconazole resistant, intrinsic resistant to fluconazole. Lusitani shows intrinsic resistant to amphotericin B. Please remember these two, which can be a probable exam question. Okay. So what infection which all are the risk group, which all group it can cause infection? So all immunocompromised patients. Then in children, it causes napkin rash. People with metabolic disorder like diabetic patients, overweight people, pregnant women, the women taking OCP, oral contraceptive pills, and who work in wet conditions, HIV positives, these or other immunodeficiency disorder patients are very prone for Candida infection. So it has been asked, pregnant woman, patient, a person on OCP, overweight patient, diabetic people, these all will be prone for Candida infections. So these are yeast-like fungus, which has hyphae and pseudohyphae. We saw the picture of these yesterday. Okay, so this has been asked, which fungus shows pseudohyphae? So please remember, Candida, any species of Candida might be given. Okay, it shows chlamydospore formations. Okay, so chlamydospore formation also has been asked recently in the NEET entrance. So chlamydospore formation is by Candida albicans, please remember. So what is Reynolds brood phenomenon or germ tube test? Okay, so when you inoculate the colony of Candida in serum and incubate for around 1.5 to 2 hours, and then examine the wet mount, you can see the elongations Okay, so that is called germ tube test, which you see positive in Candida albicans. Other species of Candida will be negative for germ tube test. So you can differentiate, you can do speciation of Candida on the germ tube test basis. So what all infection Candida can cause? It can, major infection is mucocutaneous, invasive, and it can cause candidemia. Okay, mucocutaneous, it can infect skin, hair, intergenous area. It can cause oral thrush, vaginitis, balanitis, mucocutaneous candidiasis. Then it can disseminate to various organ like lung, kidney, heart, and it can cause bloodstream infections. Thank you, friends. So we'll meet tomorrow again with some important topic in microbiology. Thank you.
Yeah, welcome back. So yesterday I have introduced you to that X-rays and in age assessment. So today I will giving you certain X-rays demonstration of how to arrive at age assessment, right? So yes, so look at this, the left side. It is a normal X-ray, right? It is a normal X-ray. for you to compare it and simultaneously learn it side by side so that you'll be clearly understanding it. So this is a normal X-ray, right? So what did I tell you about X-ray pelvis? First point is look at the ischiopubic ramus. Now ischiopubic ramus is open, right? So open ischiopubic ramus. So age will be lesser than 6, right? Lesser than 6 years. Okay. So now look at this. So compare this. So compare with the normal X-ray, right? Compare with the normal X-ray. Okay. So now, so this is so easy X-ray. So ischiopubic ramus is open. Okay. Now head of the femur is there. Okay. Now greater trochanter is just now forming. Greater trochanter is just now forming. So greater trochanter forms between 5 to 6 years. So with respect to greater trochanter, you can say lesser than 6 years, right? Lesser than 6 years. So easy, right? The answer is obtainable even in step 1. We are looking at ischiopubic ramus. Answer is done. Okay. So now I'll give you one more example. Okay. So now look at this X-ray. Now step 1 is complete, right? Now ischiopubic ramus is complete, right? Ischiopubic ramus is complete. If ischiopubic ramus is complete, now age will be more than 6, right? More than 6. Now it is more than 6. Okay. Now where should we look second? Now look at the triradiate cartilage, right? TRC, step 2, triradiate cartilage. Look at this area, right? Look at this area. Now you can see radiolucens there, right? Radiolucens is still there. So the cartilage is not completely ossified. So TRC is still open, right? So I told you about TRC, triradiate cartilage, which fuses between 13 to 15 years. Now triradiate cartilage is not ossified, so you have to take the upper limit. Now age shall be lesser than 15 years, right? 1-5, lesser than 15 years. Easy, right? Lesser than 15 years. Okay. Now with this, you can easily identify step by step. So never skip the steps I'm telling you, right? If we go through the step, you will easily identify the answer. Okay. So now I'll show you another example. Okay. Now what is step 1? Step 1 is ischiopubic ramus. It is complete. So age is more than 6. Okay. Now what is step 2? Look at the triradiate cartilage. Now triradiate cartilage is still having a bit of radiolucency, right? So a small radiolucency is still there. Okay. Now age will be lesser than 15 years. Easier, right? Okay. So now take this for example, right? Take this for example. Now step 1 is complete. Step 1 is complete. You can say more than 6 years. Ischiopubic ramus is complete. Okay. Now go for TRC, the triradiate cartilage area. Now triradiate cartilage is completely obliterated. It completely obliterated. Now age will be more than 13, right? More than 13. So if triradiate cartilage fuses between 13 to 15 years, and if the fusion is complete, you have to say more than 13 alone. More than 13 alone. Right? If the fusion is incomplete, you can say lesser than 15, right? Always remember, not united, not fused, go for the upper limit, right? Fused, appeared, go for lower limit, right? Okay. Now, step 1 and step 2 are over. Now, where should we proceed next? Yes. Now, look at the iliac crust area. This is step 3, right? Step 3 is iliac crust area. Step 3, right? Step 3 is iliac crust area. Now, iliac crust has not developed any secondary center, right? Iliac crust is same, looking similar, right? So, in the next slide, I'll tell you how iliac crust center will be, right? Iliac crust center will be, okay? So, now, see, step 1 over, step 2 is over. Now, where should we look for? We should look for the iliac crust center. So it is beautifully present there, right? The center is beautifully present there. So iliac crust appears by 14 years. The center for iliac crust appears by 14 years. So now the iliac crust has appeared, right? The center for iliac crust has appeared. So now the age will be more than 14 years. More than 14 years, right? More than 14 years. Okay, right? More than 14 years. Okay. So now we'll go to the next example, right? Now look at this example, a similar X-ray, right? A similar X-ray, the same X-ray, similar X-ray. Now we'll repeat the same exercise again. Now step 1 is over, completed, so more than 6 years. Okay. Now step 2 is also completed, right? So more than 13 years. 13 years. Okay. Now we'll go for step 3, which is iliac crust. Iliac crust is formed. The center is there, right? You could see a cap-like secondary ossification center here. Cap-like secondary ossification center. Okay. Right. Now age is more than 14 years. Okay. Now this looks incomplete, right? You have just said age is more than 14 and you have not set the upper limit. Now age will be in ranges, right? 14 to 15, 14 to 16, yes. Now what will be the upper limit? Then comes the last part. The last part you have to look for is the ischial tuberosity, right? The ischial tuberosity here, right? The ischial tuberosity center. Okay. So now you could see in this X-ray. So step 1 here, step 2 here, step 3 here, and lastly the iliac or ischial tuberosity center will be here, right? The last step, ischial tuberosity. Now the ischial tuberosity center is like a streak, not yet formed. It is a streak, a small streak here, right? You could see a small streak line, right? So I'll erase it and you could see it again, a small streak here, right here, small streak. Now ischial tuberosity has formed. Now if ischial tuberosity is formed, appearance of ischial tuberosity is 16 years, right? 16 years. So one side the ischial tuberosity has formed, iliac crust has formed, so age will be 14 to 16, right? 14 to 16. Okay. Now, so this is another beautiful X-ray where step 1 is so clearly seen. Step 2 is also clearly seen and completed. And look at the step 3, the iliac crust, right? Iliac crust, right? Iliac crust center is also there. 3 steps are over, right? 3 steps are completely over. Now we have to go for the 4th and final step, that is looking at the ischial tuberosity center here. Ischial tuberosity center there, right? Ischial tuberosity center. Now if ischial tuberosity has appeared, then age will be 16, right? 16 years. Okay, 16 years. Now, what is the concluding point in X-ray pelvis, right? So we have gone for all 4 steps of secondary ossification fusion. Okay, now what will happen eventually to all these centers? Now the center for iliac crust and ischial tuberosity will fuse with the corresponding parts of the pelvis. Now iliac crust center will fuse with ilium. Ischial tuberosity center will fuse with the ischium. Okay, right? So and then at the end you will be having a bone in this way. Bone in this way. No radiolucence, right? No radiolucence. No radiolucence, right? Complete fusion will be in this way. Now when this fusion gets completed for iliac crust and ischial tuberosity, now the fusion gets completed by 21 years for iliac crust and ischial tuberosity. Iliac crust and ischial tuberosity both would fuse by 20 to 21 years, right? 20 to 21 years. So easily by looking at the centers, you can say center for iliac crust is there, center for ischial tuberosity is there. So age will be more than 16 years. Okay. Now still radiolucency is present. The center has not completely fused with the corresponding bone. So age of fusion is 21. Now you can take the upper limit lesser than 22 or lesser than 21 years. Right? So more than 16 years, lesser than 21 years, right? So easy, right? So easy to remember. Okay. So tomorrow I'll be bringing you about wrist joint, right? So only pelvis and wrist joint are repeatedly asked X-rays with respect to INICET. So INICET has direct predilection towards X-ray pelvis and X-ray wrist. Okay. So now that's it for today. And tomorrow I'll be dealing you all with X-ray, wrist, and age estimation, right? Okay, thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Yeah, good evening, everyone. So today we'll be discussing about the tumors, mainly our retinoblastoma. Okay, the tumor today we'll be discussing about is retinoblastoma. Okay, so okay. So we have to remember what is the other name for retinoblastoma. Should remember that the other name for retinoblastoma is glioma retinal. So the other name for retinoblastoma is glioma retinal. Okay, so it is a primary. What type of a tumor it is? It is a primary intraocular malignancy, typically seen in the childhood. Okay, it is a primary intraocular malignancy seen in the childhood. Typically, it is seen in the first few days of birth. So the infant, within the first few days of birth, if you see a white reflex, then it indicates the presence of retinoblastoma. Okay. Yeah. So what is the etiology? Okay. The etiology, we should know that the tumor gene responsible is the RPE1 gene. Okay. So the tumor gene responsible is RPE1 gene, which is present on the chromosome 13q14. 13q14 is the locus of the gene. Okay, what type of a gene is it? It is a tumor suppressor gene. It is a tumor suppressor gene. Okay, so glioma retinae, also known as retinoblastoma, is the primary intraocular malignancy. The tumor suppressor gene is present on locus 13q14. Okay, so remember, according to the Knudsen's two-hit hypothesis, both the alleles of the gene have to be inactive for the tumor to manifest. Both the alleles of the gene have to be inactivated. Okay, so the timing of loss or inactivation, yeah, just a minute. So the timing of the loss of mutation or inactivation of the gene, will determine whether there is a germinal cell involvement or if it is inherited by the offspring. Okay, if it is germinal cell involvement or if it is inherited by the offspring. Okay, so you should know about, so three main things you should know about in retinoblastoma. First is the rosettes. Should know about the florets. Okay, rosettes and florets. So what are the various types of rosettes present in retinoblastoma? We have the Flexner Wintersteiner rosettes. Flexner Wintersteiner rosettes are the true rosettes present in retinoblastoma. So this is the typical appearance of the Flexner Wintersteiner rosettes. Remember, these are highly characteristic of retinoblastoma. Highly characteristic of retinoblastoma. Okay. Next, we have the Homerite rosettes. Typically, if you see the, so this is the floret. The Homerite rosette, if you typically see Homerite rosette, it is arranged in a radial pattern. Okay, the radial pattern of arrangement is seen in a Homerite rosette. Remember, Homerite rosette is a false rosette. It is not a true rosette. The true rosette in a retinoblastoma is the Flexner Wintersteiner rosette, which is highly characteristic of retinoblastoma. Okay, so this is the presentation. Histopathology you should know. You should know about the florets. You should know about the rosettes in retinoblastoma. Next, coming to the diagnosis. So how do you diagnose a case of retinoblastoma? So what are the various investigations you want to do in a patient with retinoblastoma? So remember the investigations, we have to first do the X-ray of the orbit. X-ray of the orbit will typically show the calcification of the tumor. The calcification of the tumor is seen on the X-ray of the orbit. Then we have to do the ultrasonogram. Ultrasonogram, again, we can see the appearance of the calcification on ultrasonography or B scan. And also your CT and MRI is used for diagnosis. Again, the calcification becomes clearly seen in the CT and the MRI. Also remember the serum LDL level in the aqueous. Okay, if the LDL level in the aqueous is increased in cases of retinoblastoma. So if we take a sample of the aqueous and check for the LDL levels, the LDL levels are increased in retinoblastoma. So these are the important investigations we do in a patient with retinoblastoma. Okay, so again we can do a PET scan to see for the presence of distant metastasis. Again, remember the distant metastasis, it metastasizes to the bone marrow and spleen. It metastasizes to the spleen and bone marrow. Okay, so recent INICET question paper and also in your previous NEET paper, we got a question on retinoblastoma. So we'll be discussing retinoblastoma in detail today. We should also know about pinealoblastoma. What is pinealoblastoma, or what is a trilateral retinoblastoma? So a trilateral retinoblastoma is a bilateral retinoblastoma along with the pinealoma. So if the retinoblastoma is bilateral along with the pinealoblastoma or a pinealoma, it is known as a trilateral retinoblastoma. Okay, so we should know which is the most common secondary tumor in a patient with retinoblastoma. Remember, the most common secondary tumor in a patient with retinoblastoma is osteosarcoma. So osteosarcoma is seen up to 37% of the patients. In up to 37% of the patients, we see osteosarcoma. So what is the presentation of this patient? How does the patient typically present? So the most common presentation is, most common presentation is leukocoria. Leukocoria is the white pupillary light reflex. So we should know about the important differential diagnosis for leukocoria. So apart from retinoblastoma, we should also remember congenital cataract can result in leukocoria, ROP can result in leukocoria, a PHPV can result in leukocoria, a toxocara infection can result in leukocoria, a retinal detachment, a retinoschisis. So all these are important differential diagnosis for leukocoria at birth. Okay. Next, coming to the management. Again, the management of the tumor. What are the important things which determine the management of the tumor? It depends upon the size of the tumor. It depends upon the laterality. So if it is a unilateral or a bilateral tumor. Okay, and also the most important prognosticating factor is the vision which is present in the patient. So if the patient is having PL or no PL vision in the eye, then definitely the tumor is more advanced and we may have to plan for a enucleation procedure. Okay, so all these are important in prognosticating the tumor and coming to the management. Okay, another important factor we have to take into consideration is the age of the patient and the general health of the child. Okay, the age of the child and the general health of the child. So remember, when the patient presents with retinoblastoma, they can come in the advanced stages. So they may have an associated present retinal detachment. They may have presence of vitreous seeding, vitreous hemorrhage may be there. They can also have a neovascular glaucoma and other secondary glaucomas. So this is the typical presentation of the patient. Okay. So the prognostication was explained by the Rees-Ellsworth classification. So the Rees-Ellsworth classification, they divided the tumor into 5 groups, and based on the tumors in which we have to salvage the affected eye, and in the tumors which had a favorable prognosis, we could retain the eye. Okay, so that was prognosticated by the Rees-Ellsworth classification. So what do we have in the Rees-Ellsworth classification? The first group is a very favorable prognosis. The group is a very favorable prognosis. So if it is a tumor which is less than 4 disc diopters in size, okay, the tumor should be less than 4 disc diopters in size, and it should lie behind the equator. Okay, so it should either be a solitary tumor less than 4 disc diopters behind the equator, or it can be a multiple tumors not more than 4 disc diameters and should lie behind the equator. So these will have a favorable prognosis, very favorable prognosis. Next, the group 2 favorable prognosis, tumor 4 to 10 disc diopters in size and behind the equator. Again, remember, if it is lesser than 10 disc diopters, the prognosis is usually favorable, and if it lies behind the equator, it is a better prognosis. If it lies in the posterior pole, if it's larger than 10 disc diopters, if there's vitreous seeding, if there's a massive tumor with spread to the distant metastasis, so all these are poor prognosticating factors. So size more than 10 disc diopters, tumor lying anterior to the equator, tumor extending up to the ora serrata involving the posterior pole, tumor with vitreous seeding, okay, and tumors with having a distant metastasis. These are all poor prognosticating factors according to the Rees-Ellsworth classification. Okay, so this is the typical ultrasound imaging which shows the presence of a size of the tumor. So what is the use of the B scan? The B scan will show you the size of the tumor, it shows you the shape of the tumor, it shows the orbital involvement, the optic nerve involvement, the extrascleral calcification or extrascleral extension can be seen along with calcification. So these are the things which can be made out with your B scan. Okay, the size, the shape, the extent, the calcification of the tumor can be made out in B scan. Next is the CT. Again, the CT will show the presence of a hyperdense foci which corresponds to the calcification. So this is the calcification seen on the CT of this patient. Again, it can show the involvement of the optic nerve. So if they ask you which is the best investigation to check for the optic nerve involvement, it is your MRI. Okay, so the MRI is best to check for the optic nerve involvement. So this again, it shows the extent of the tumor, the involvement of the optic nerve, extraocular extension, and it helps to differentiate retinoblastoma from other simulating lesions. Okay, so the investigation for checking the optic nerve involvement is your MRI. The investigation of choice is the MRI. Coming to the various modalities of treatment, I told you again, depending upon the size of the tumor, the location of the tumor, the visual potential in the patient, the general health of the patient, and presence of other secondary glaucomas and retinal presence of retinal detachment, we take a call on whether we have to enucleate the eye, accentrate the eye, or go in for a chemotherapy, local therapy like chemotherapy, external beam radiotherapy, or systemic chemotherapy. Okay, so again, you should remember the procedures for surgery is enucleation and accentration. Again, when we are doing an enucleation, we have to remove about 10 millimeters of the optic nerve head. About 10 millimeters of the optic nerve head has to be removed along with the tumor in case of a enucleation. If there is an extrascleral spread, if there's involvement of orbital tissue, then we have to do an accentration procedure. So accentration is a more, so we'll have to remove the forehead, the skin along the forehead, along with the muscle and the bone. Okay, in case of the accentration. Next, coming to the cryotherapy. So we should know about the various chemotherapy regimes which are present for this one. So we have chemotherapy. So the most common chemotherapeutic regimen which is used for retinoblastoma is the CEV. Okay, so we give 6 cycles of carboplatin, etoposide, and vincristine. So this can sometimes be combined with a cyclosporin also. cyclosporin, which is a calcineurin inhibitor. Cyclosporin can also be used. This is the most common chemotherapy regime which is used for retinoblastoma. Again, we have to give 6 cycles of CEV in patients with retinoblastoma. So when is chemotherapy preferred? Chemotherapy is preferred when there is an extraocular tumor extension, extraocular tumor extension. So if there's an intracranial metastasis, intracranial spread, and if there's a metastatic disease. So when do we do chemotherapy? We do chemotherapy if there's an extraocular tumor extension, if there's an intracranial tumor, if it is a metastatic tumor. Okay. So this is the iodine 125 plaque. Okay, iodine therapy also it is usually done for solitary tumors, solitary lesions which are 2 to 16 millimeters in size. We can do iodine 125 plaque therapy. This is also known as external beam radiotherapy. Okay, local recurrences following the external beam radiotherapy, we can put in an iodine 125 plaque. So transpupillary thermotherapy is also one of the modalities which can be used for the treatment of the tumor. Again, tumor which is more peripheral, tumor which is less than 4 disc diopters in size, tumor which is not involving the posterior pole. So these are ideal for doing a transpupillary thermotherapy. Okay, so this is the same picture. So this is the tumor before the procedure, and this is the same tumor after the transpupillary thermotherapy is given. Okay, so this is the appearance of transpupillary thermotherapy. Okay, so with this we finish the class for today. Okay, hopefully this is useful.
of all the dimensions, I mean the length, the breadth, the thickness, all the dimensions, the diameter of the orifices as far as gynec anatomy is concerned. So like how we study gynec anatomy, we usually study, like we take one particular organ, say cervix, and study every points about cervix. Then later on we'll talk about isthmus, and then we'll start to dealing with every points about isthmus. Now this is a collective information that I am bringing to you about the dimensions of all the organs of the female genital tract. So let's begin our class now. So lower genital tract. So the female genital tract, you all know, we are dividing it as upper genital tract and lower genital tract. Where is the line of demarcation? Now, the line of demarcation is somewhere here. Maybe at the cervix, okay? So cervix, vagina, vulva, the external genitalia. So now this will constitute the lower genital tract. This will constitute the lower genital tract. Uterus, tubes and ovary, and of course the peritoneum, because we know female anatomy is very peculiar in that it communicates with the peritoneum itself. Yes or no? Peritoneal cavity is communicating with the exterior. So here peritoneum. So now this is the upper genital tract. Uterus, tubes and ovary, upper genital tract. So lower genital tract infections, when we talk of lower genital tract infections, we talk of vaginitis and cervicitis. Any lower genital tract infection has to be meticulously treated, because that can lead to upper genital tract infection. That can lead to infection of the, say, endometrium, which is called endometritis. So here it will be endometritis. Infection of the tubes. So when we say tubes, then it is salpingitis. Salpingitis. And then we can also talk about what? Infection of the ovaries, which is oophorytis. Okay. So it can be anything. So it can be ascending infection. And endometritis, oophorytis, salpingitis can lead to pelvic peritonitis. Okay. Now this is PID. So now this is pelvic inflammatory disease. Infection of the organs of the upper genital tract is pelvic inflammatory disease. So when we talk about pelvic inflammatory disease, we'll be talking about endometritis, salpingitis and oophorytis and peritonitis. So that's clear. Now we'll talk about the dimensions. So this class is wholly focused on teaching you the dimensions. We had already talked about the cervix. Now this is the cervix, and we know the anterior vaginal wall and the posterior vaginal wall. Now the anterior vaginal wall and the posterior vaginal wall. So I already told you that the posterior vaginal wall is attached at a higher point on the cervix. Therefore, the posterior vaginal wall is longer than the anterior vaginal wall. Posterior vaginal wall is longer than the anterior vaginal wall. The anterior vaginal wall dimension, now it is 7 centimeters. Posterior vaginal wall, it is 9 centimeters. Is that okay? Anterior vaginal wall 7 centimeters, posterior vaginal wall 9 centimeters. Okay, now the anterior vaginal wall is related to the urethra and the bladder, right? The anterior vaginal wall is related to the urethra and the bladder. So here are questions that will be commonly asked are, what is the length of female urethra? It is 4 centimeters. Is it okay? And what is the diameter of the urethral orifice? It is 6 millimeters. Okay, it is 6 millimeters, because this class of 15 minutes is wholly about all the numbers and the dimensions, because almost every point that I say in today's class now was a question in the previous exams. Okay, now when we talk about bladder, the most common things that will be asked with reference to bladder are, what is the bladder capacity? What is the maximum bladder capacity in females? The maximum bladder capacity in females is around 500 ml. So we can write it as a range 400 to 600 ml. Okay. Now, the other questions that are usually asked here are, the first sensation to void. The first sensation to void is felt at a bladder capacity of how much ml? It is 150 ml. Okay, the first sensation to void is felt at a bladder capacity of 150 ml. A strong urge to void strong urge to void. This is felt at a bladder capacity of 250 ml. And the last question that would always come in the series is how much is the usual residual urine volume? Okay, now the residual urine volume, is somewhere should be less than 50 ml. Okay, now all these will definitely come in the exams. Now, with reference to the attachment of the cervix to the vagina, you can see now all around there are dead spaces called fornices. So totally how many fornices are there? Now, if this is the attachment of the vagina to the cervix, now totally all around there are 4 fornices. 4 fornices. So what are the 4 fornices? Anterior fornix, then you have the posterior fornix, then you have the 2 lateral fornices. Posterior fornix, then you have the 2 lateral fornices. Anterior fornix, posterior fornix, and then you have the 2 lateral fornices. Now, which is the deepest fornix? Posterior fornix is the deepest fornix. And which is the shallowest fornix? Anterior fornix is the shallowest fornix. Is it okay? Fine. Now, with reference to the length of the cervix, so we had already done with the length of the cervix yesterday. Now, if we tell it as a range, it is somewhere between 2.5 to 4 centimeters. When we say it as a single number, we usually denote and tell it as what? 2.5 centimeters. So, all the numbers with reference to the lower genital tract, that is the vagina, and we have also talked about the cervix. We have additionally talked about the urethra and the bladder, important points. Now coming on to the uterus. The dimensions of the uterus, when you take textbook, the dimension of the uterus is clearly given as 3 into 2 into 1 inch. So it's always given in inches, and this is only for easy remembrance. Now we need to convert it into centimeters, and if we convert into centimeters by multiplying by 2.5, it would come as 7.5 centimeters into 5 centimeter into 2.5 centimeter. Now is that right? Okay, so I'll tell you, you have to round off the 7.5 as 8. Okay, so 8 into 5 into 2.5 centimeter. If someone asks you the dimension of the uterus, you should say 8 into 5 into 2.5 centimeters. So it's very difficult for us to remember. That's why we remember as what? 3 into 2 into 1 inches. Is that okay? Now, what is 8? 8 is a length. What is 5? 5 is a breadth. And what is 2.5? 2.5 will be the thickness. Okay, fine. Now we will talk about all these numbers. So I've drawn uterus, then I'm drawing the cervix. Okay, of course I'm drawing the vagina, then I'm drawing the uterine lining. Is that okay? Fine. Now we need to remember that what is the length of the cervix? The length of the cervix is 2.5 centimeters. Okay. Just above the cervix, now we have a region called the isthmus. Just above the cervix, we have a region called the isthmus, which is 0.5 centimeters normally, that is 5 mm normally, isthmus, which becomes 10 centimeters in pregnancy. Now, isthmus is the one which gets converted to what? Lower uterine segment. So now this becomes 10 centimeters in pregnancy. Now, isthmus in pregnancy is called lower uterine segment, where we will make the lower segment cesarean section incision. Is that okay? Now, please remember, now we'll go to this, we'll focus on this. This 8 refers to the total length from here to here, from the fundus tip up to the external os. Now, I hope you're able to understand. So, 2.5 plus 5 plus something is equal to 8. Now, this is totally is equal to 8. 8 centimeters. Now let us focus only on this. Only from the fundus up to the isthmus. Let me take black color here. So only from the fundus up to the isthmus. So this should be, now this should be how much centimeters? Now already 3 gone. So this should be 5 centimeters. So 5 centimeters means fundus to isthmus. Now remember, in the uterus, in the fundus, there is no cavity. In the fundus, there is no cavity. no cavity in the fundus. So if a question in the exam comes like, what is the length of the uterine cavity? Now this 5 we are dividing as, okay, this is 1.5 and this is 3.5. I hope now you are able to understand. Okay, so this 5 is being split as 1.5 centimeter is the thickness of the fundus and actual length of the cavity is 3.5 centimeters. I hope I'm very simple. Okay, so I repeat again, to remember the dimensions of the uterus, you need to remember 3 into 2 into 1 inches. Convert it into centimeters, it becomes 7.5 into 5 into 2.5 centimeter. Now that 7.5 you will be rounding up as 8. This 8 into 5 into 2.5. Now what does this 8 signify? Now this is from the fundus up to the external os. You know cervix is 2.5, you know isthmus is 0.5, so already 3 gone. You have remaining 5 centimeters, which is from the fundus to the isthmus. Now that 5 centimeter can be divided as 1.5 centimeter will be fundus and 3.5 centimeters will be cavity. So in the exam, if you have the question as what is the length of the cavity? So if you have a question as what is the length of the cavity, now you should say 3.5 centimeters. Is that okay? What is the total length of uterus if they ask? Then it means from the fundus up to the external os. You will write as 8 centimeters. I think I have done justice to the dimension of the uterus. Okay. Now let's go to, okay, leave this off. Now let's go to fallopian tubes. Okay. Now if we take the fallopian tubes, okay, now I'll draw. Now we have important parts of the fallopian tube. Now this is the medial most part of the fallopian tube, which is called the intramural part or interstitium. So I am talking about parts of the fallopian tube from medial to lateral. So this is intramural interstitium. And then we have isthmus. Okay. So after isthmus, we have ampulla. And you can see ampulla is the longest and the widest part. You have the ampulla. And then after ampulla, we have the infundibulum. Now this is the infundibulum. Infundibulum, lateral to which we will have the fimbrium. Okay. Now, when we talk about the, here also we are talking about dimensions. In the exams, you do get questions as tell the parts of the fallopian tube from medial to lateral, or sometimes they will ask from lateral to medial. Okay, so you can study intramural, isthmus, ampulla, and infundibulum. So if we take these 4 parts, now this comes to roughly around 10 centimeters. If you take total length of the tubes, now this infundibulum, this fimbria, another 2 centimeters. So if you want to approximate the total length of the tubes, you say, I mean, one tube, 10 to 12 centimeters. Now we will talk about the length of each part of the tube. So start with 1.25. So the double of 1.25 is 2.5. Now the double of 2.5 is 5 centimeters. And then again start with 1.25 centimeters. Now when you add all this, it will definitely come to 10 centimeters. Okay, so when you add all this, it will definitely come to 10 centimeters. So 1.25 plus 2.5 plus 5 plus 1.25. Okay, the total length of the tube is 10 to 12 centimeters. Fine. So what is the longest portion of the fallopian tube? Ampulla. What is the widest portion of the fallopian tube? Again, this is the ampulla. And ampulla is a site of fertilization, which you all know. Therefore, ampulla will be the most common site of ectopic. Okay, the fertilized ovum gets implanted there itself. Therefore, this becomes the most common site of ectopic pregnancy. Okay. Now, the second most common site of ectopic is the isthmus. Also remember this. We'll be talking more on this on the in the ectopic class. Second most common site of ectopic gestation. Okay, now is that okay? So now we have done with the dimensions of the vagina, cervix, uterus, fallopian tubes. What is left is the ovary. Before we go on to that, we finish up all these questions, which I've already told. Longest portion of the fallopian tube is ampulla. Widest portion of the fallopian tube is ampulla. What is the narrowest portion? It is interstitium. The site of fertilization is ampulla. The most common site of ectopic pregnancy is also ampulla. And the second most common site is isthmus. Okay, so we are left only with studying the dimensions of the ovary. So when we talk about dimensions of the ovary, now this is going to be very simple. We all know ovary is almond shaped. So we have one length, we have one breadth, and we have one thickness. So like we studied uterus, dimension is 3 into 2 into 1 inches. Now for ovary, it's very simple to remember. It is 3 into 2 into 1 centimeters. So that is the end. I'll just take some another 30 seconds of time to finish up all the questions, just 2 to 3 questions. The size of the uterus in inches is 3 into 2 into 1 inches. Okay. If you talk about ovary, it is centimeters. Longest part of the fallopian tube is the ampulla. Length of the fallopian tube is 10 to 12 centimeters. Okay. Weight of nulliparous uterus, you just have to remember this. Weight of nulliparous uterus is approximately 70 grams. And here you can choose 60 to 80 grams. Okay. The narrowest part of the fallopian tube is, of course, the intramural part or the interstitium. This is one question which is addition, which I have not discussed in the class. What is the length of a round ligament? It comes to around 10 centimeters. So finally, to sum up, we have done with almost all the dimensions and numbers only. So you can collectively make a notes or a picture or a drawing of all this with the numbers written side by side, which will be helpful for your reference. Okay. So thank you for your patient listening. I'll meet you tomorrow in another session. Thank you.
So today's class will be on anti-malarial drugs. So first, before going into the anti-malarial drugs, we'll just check the life cycle of malarial parasite. So what happens when a female Anopheles mosquito comes and bites an individual? The sporozoites are first released into the blood. So from here, the sporozoites quickly go into the liver. So what happens when it goes to the liver? It gets formed, it forms a hepatic scission. That means asexual reproduction of the sporozoites takes place in the liver. So an hepatic scission is formed. It multiplies in such a way till it can hold this merozoites in place. So once it gets bulged enough multiplication has taken place, the merocytes are released into the bloodstream. So the stage where it is present in the liver, it is called as the pre-erythrocytic stage. The stage where it is released, this merocytes gets released into the blood is called as the erythrocytic stage. So once these merocytes are released into the blood, they start multiplying in numerous numbers till the RBCs gets burst and releases it completely. So this is the stage where you get fever. So what is responsible for the acute phase of malaria is your erythrocytic stage. In the liver, it is called as pre-erythrocytic stage. So out of all the merocytes that is released here, few merocytes becomes dormant in the liver itself. So they don't come out, they stay in the liver itself. So that is called as exoerythrocytic stage, dormant stage. So this is what is responsible for your relapse in case of Vivax. So once it is released into the blood, the erythrocytic stage is completed. Again, a new mosquito comes and sucks your blood while it is biting you. The gametes are getting released into the bloodstream of the mosquito. So fertilization takes place, a ookinete is formed, a oocyte is formed, and finally sporogenesis happens. Again, the female mosquito is ready to inject the sporozoites when it bites a new patient. So quickly summarizing the life cycle of malarial parasite. First, it's the bite of female Anopheles mosquito. Sporozoites are released. Everything goes into your liver, where a hepatic sysont is formed. So that stage is called as your pre-erythrocytic stage. So when that stage is getting completed, the merocytes are released into the blood. So when they are released into the blood, that is called as your erythrocytic stage. So this is what is responsible for your acute phase of malaria. So the patient present with all symptoms of malaria, mainly fever. So some of these merocytes remains dormant in the liver itself. So that is responsible for your relapse, which is seen in case of Plasmodium vivax. So after the erythrocytic stage, a new mosquito comes and bites the patient. It takes these sporozoites inside. Gametes are going inside. Gametogenesis happens, multiplication. Then fertilization takes place. An oocyte gets formed. Then sporogenesis happens. And again, the life cycle keeps continuing when a new patient is infected. So now, depending upon the stages I have told you, there are 4 stages here: pre-erythrocytic, erythrocytic, exoerythrocytic, and gametogenesis. So based on that, we will classify the malarial drugs. So first is your tissue sysanticides. That is nothing but those drugs that acts in your pre-erythrocytic stage. So these drugs act in your pre-erythrocytic. That is only in your liver tissue. So easy, pre-erythrocytic. So 3 P's. Remember it? 3 P's. Primaquine, proguanil, pyrimethamine. What is that? 3 P's: primaquine, proguanil, and pyrimethamine. Next comes your erythrocytic sysanticides. That is nothing but those drugs that act in your blood. When the malarial parasite is in your sporozoites in your blood, it acts. So this is responsible for clinical cure. That is because it acts in the acute stage. So I classify these drugs as 2. One is fast acting, other one is slow acting. Easy to remember, fast acting, the quinines mainly. So chloroquine, quinine, and the ACT. That is nothing but your artemisinin. And one more new drug is mefloquine. So there are So I'm sorry, I think now again we are back. Please don't mistake. So let's take a look at from the beginning. So drugs for malaria, I classify it as first degree. So drugs for malaria, I classify it as first degree schistoscides. So we saw that as 3Ps, which acts only in your hepatocytes. So that is in your liver. So that is used for causal prophylaxis. They are used only for your causal prophylaxis. So the second is your erythrocytic schistoscides. The erythrocytic schistoscides are nothing but those acts in your blood. So that is used for your acute phase. So what are the drugs? That is fast acting and slow acting. So how do you classify that? For fast acting, I told, remember MAC, that is mefloquine, artemisinin, chloroquine and quinines. For slow acting, remember 2Ps, that is proguanil and pyrimethamine. So this is only used for your acute phase treatment. So third is your exoerythrocytic, that is, I told you what is exoerythrocytic phase. It is nothing but dormant stage. The merocytes go settle in your liver. That is responsible for relapse. So whenever you treat a patient, you also have to radically cure the patient. So it is used for radical cure. Only one drug acts in the exoerythrocytic schistoscide. That is nothing but your primaquine. For controlling the gametocytes, what is gametocytes do? They stop the prevention because the gametes cannot enter into the next mosquito. So there is no fertilization, zygotes cannot form. So sporogenesis doesn't happen in the female Anopheles mosquito. So mainly the gametocytes are classified as chloroquine and quinine. This chloroquine and quinine is used only for your falciparum, for your Plasmodium vivax. Whereas 3Ps, which I told you already, that is proguanil, primaquine and pyrimethamine. They are also used for both falciparum and vivax. Remember this, for gametocytes, you have chloroquine and quinine, which is used only for Plasmodium vivax. But for proguanil, primaquine and pyrimethamine, along with artemisinin, you can use it for both falciparum as well as vivax. So there are 4 stages, different types of drugs. Repeating, tissue schistoscides, 3Ps, erythrocytic acute phase, fast acting, slow acting. Remember MAC, mefloquine, artemisinin, chloroquine and quinine is for fast acting. Slow acting, you have P, that is proguanil and pyrimethamine along with sulfonamides. Next is your exoerythrocytic, which is nothing but your relapse, that is radical cure. Merocytes settling in the liver, dormant stages, only primaquine. For gametocytes, for vivax, it is chloroquine and quinine. For both falciparum and vivax, 3Ps already mentioned, those acts here along with artemisinin. Now going to malaria, different types. How do you treat it? First is uncomplicated, other one is complicated. Let's first see the complicated malaria, which is very easy to remember. In complicated malaria, if you can see, I have classified it as males and non-pregnant and pregnant categories, both first trimester as well as second and third trimester. Remember it, complicated malaria due to falciparum. I have classified it as 3 male patients, non-pregnant females. Pregnant females, first trimester and second and third trimester. Always remember, in case of complicated falciparum malaria, use only IV artesunate in the beginning for at least for 48 hours, followed by oral artemisinin combination therapies. So there is no role for any other drugs now. As per latest guidelines, use artesunate IV, follow it with oral artemisinin combination therapies. So now coming to uncomplicated malaria, depending upon the symptoms, for vivax, let's see. Similar classification. Males, non-pregnant, we use chloroquine with primaquine. What we use? We use chloroquine with primaquine. So all non-pregnant females and males can be treated with chloroquine, both the quinines, chloroquine and primaquine. But this primaquine should be given for 14 days. Why 14 days? To reduce your dormant stage, to control the relapse. That is for radical cure. But one point here is why this primaquine is not used in pregnancy. Only chloroquine is used. If you see here, it is because primaquine is contraindicated in pregnancy as well as in G6PD deficiency. It can cause hemolytic anemia. Remember, uncomplicated malaria, falciparum vivax, Plasmodium vivax, males non-pregnant, chloroquine with primaquine. Primaquine given for 14 days. That is for radical cure to prevent the relapse. Contraindicated in pregnancy and G6PD deficiency because of hemolytic anemia. Whereas in pregnant females, you go only with chloroquine, all the trimesters. Now coming to Plasmodium falciparum. For males and non-pregnant, you use artemisinin combination therapies along with primaquine. So this primaquine here is given as single dose. It is not given for 14 days. That's the difference. One single dose is enough for falciparum because the rates of relapse with falciparum are very low. They don't occur usually. But still we treat it to make sure that there is no parasites in the liver, in the tissues. So it is for just single dose. In case of pregnant, for first trimester, go for quinine. In case of pregnant females, for first trimester, in case of falciparum, go for quinine. Second and third trimester, go for ACT, that is artemisinin combination therapies. For mixed infections, it is same like falciparum. For males non-pregnant, use ACT with primaquine single dose. For pregnancy, first trimester quinine, second and third trimester ACT. So quick. And one more thing which you have to note here, one point which they can ask in AIMS is, when you are treating a falciparum infection, in case of cases that are coming from northeastern India, the combination that is supposed to be used is artemether plus lumefantrine. Don't use any other combinations. If a question is asked like this, if a 40-year-old male patient coming from northeast India has been affected and diagnosed with falciparum in peripheral smear, what is the drug of choice? So you have to straight away go for which combination of ACT, artemether plus lumefantrine along with primaquine, 1 dose. For the rest of India, we use the combination artesunate plus sulfadoxime by pyrimethamine. So if it is northeastern part of India, we go for artemether plus lumefantrine. If it is rest of India, we go for artesunate plus sulfadoxime bar pyrimethamine. So now, what are the ACT combinations that are recommended by WHO? So first, we take artesunate. With artesunate, what all can be used? Mefloquine can be used. Amodioquine can be used. That is 1, 3, and 5. Artesunate with mefloquine, artesunate with amodioquine, artesunate with sulfadoxime bar pyrimethamine. So the last combination, that is artesunate with sulfadoxime bar pyrimethamine, is the most prevalent combination that is used in India, rest of India. If it is northeastern part of India, we go for artemether plus lumefantrine. One more combination is dihydroartemisinin with pipraquine. These are the 5 combinations that is accepted by WHO. They recommend this. What is those? Artesunate combined with mefloquine, artesunate combined with amodioquine, artesunate combined with sulfadoxime and pyrimethamine. In the rest of the India, we use artesunate, sulfadoxime by pyrimethamine. But in northeastern states of India, we use artemether plus lumefantrine. The last combination which is approved by WHO is dihydroartemisinin plus pipraquine. So coming to chemoprophylaxis of malaria. So why do you need this chemoprophylaxis? Supposedly you are traveling to an endemic area. Let's assume. So you can contact malaria there. So whenever you are traveling to an endemic malaria area, there are 2 types of chemoprophylaxis. One is short term, which is for less than 6 weeks. The long term is greater than 6 weeks. For short term, always doxycycline. For long term, always mefloquine. So how do you use it? So supposedly, if you are traveling to an endemic area and it's for a short term, you want to use doxycycline, it should be given 2 days before the travel. How much? 2 days before the travel and 4 weeks after leaving the endemic area. And 4 weeks after leaving the endemic area. So you give it before the travel, you continue during the stay, and when you come back 4 weeks after the leaving the endemic area, you should still continue the drug. But it is contraindicated in pregnancy and children less than 8 years. Remember, contraindicated in pregnancy and children less than 8 years. If you are going for a long-term prophylaxis, if your stay is more, if you are going to stay for more, so what you have to do is you go for 2 weeks of mefloquine. Here it is 2 days. Doxycycline is for 2 days, whereas mefloquine is for 2 weeks before the travel and 4 weeks after leaving the endemic area. So where it is contraindicated, one of the symptoms that is seen with mefloquine as an adverse effect is neuropsychiatric problems or convulsions. So you should not use in convulsions, patients with history of convulsions and neuropsychiatric problems. So just quickly summarizing the entire class, life cycle of malaria divided into 4 phases: pre-erythrocytic, erythrocytic, exoerythrocytic, and gametocytic. So pre-erythrocytic, it's liver. Erythrocytic, it's blood. Exoerythrocytic, dormant stages in liver, usually causing relapse. Erythrocytic stage responsible for fever, that is the acute phase. That gametocyte is responsible for fertilization and multiplication and producing more sporozoites. So the life cycle continues. So going into the drugs, 4 phases. First phase, that is pre-erythrocytic, tissue isotonics used for causal prophylaxis. 3 Ps, primaquine, proguanil, pyrimethamine. Erythrocytic, it's used for acute cure. Fast acting, slow acting. Fast acting mnemonic is MAC, mefloquine, artemisinin, and chloroquines. Slow acting is proguanil and pyrimethamine along with sulfonamides. Exoerythrocytic, usually treating for relapse, radical cure, only one drug, primaquine. Gametocytes, I already told you, if it is Vivax, it's always quinines, chloroquines, and quinines. If for both falciparum and Vivax, 3 Ps, that is proguanil, primaquine, pyrimethamine can be used, along with artemisinin can also be used. So coming to uncomplicated, complicated malaria, whatever it is, males, non-pregnant, pregnant, go for artesunate IV for first 48 hours, then follow it by oral ACT combination therapies. For uncomplicated malaria, for Vivax, if it is males but non-pregnant, go for chloroquine with primaquine. Primaquine for 14 days, radical cure, contraindicated in pregnancy because of hemolytic anemia, also in G6PD deficiency. For pregnant females, only chloroquine, don't give primaquine. If it is falciparum and mixed infections, the more or less the treatment remains the same. For males and non-pregnant, you use ACT with primaquine, 1 dose of primaquine. ACT, northeastern state, artemether plus lumefantrine. Rest of India, artesunate plus sulfadoxime by pyrimethamine. If it is pregnancy, first trimester, go for quinine. Second and third trimester, go for artemisinin combination therapies. Who recommended only 5 combinations? 3 sunate, 1 mether, and dihydromesnins. Artesunate mefloquine, artesunate amiodarone, artesunate sulfadoxime pyrimethamine. Most commonly used is number 5, artesunate with sulfadoxime pyrimethamine in India, rest of India. In northeastern part, artemether plus lumefantrine is used. The last one is dihydroartemisinin with piperaquine. Coming to chemoprophylaxis, short term less than 6 weeks, long term greater than 6 weeks, doxycycline, mefloquine. Doxycycline means it's 2 days before travel, mefloquine 2 weeks before travel. And 4 weeks after leaving the endemic area is same for both the drugs. Doxycycline contraindicated in pregnancy and children less than 8 years. The mefloquine contraindicated in convulsions, history of convulsions, patients with history of convulsions and neuropsychiatric problems. So that is for today's class. So I hope with this, you can answer all the questions in anti-malarials with respect to treatments, protocols, and how you treat, even if it is asked in a case-based scenarios. I think it's very easy to answer if you follow my slides. These 6 slides will help you, guide you through answering all the MCQs that are asked in major exams, especially from AIIMS. Yeah, thank you.
Hello, am I audible? Okay. Hello everyone, I'm Dr. Sneha, and today we'll be discussing on how to approach an MCQ in relation to disorders of sexual differentiation. Okay, let's look at an MCQ. Congenital adrenal hyperplasia can lead to the following presentation. Your options are Your options are 46XX DSD. DSD is disorder social differentiation. 46XY DSD, ovotesticular DSD, and external genitalia of female appearance. So what will be the answer in congenital adrenal hyperplasia? So let's look at what disorders of sexual differentiation means. It means that a patient will have a chromosome of one gender, but their external appearance will be that of the opposite. For example, usually we know that every female will have a genotype of 46XX. So if you do a karyotype for that lady, it will be 46XX. But when you look at her from outside, all her physical appearance will look like that of a male. So when there's a mismatch between her karyotype and the external appearance, that's when we call it as disorders of sexual differentiation. Previously, they were termed as pseudo-hermaphroditism or hermaphroditism. Okay. Previously, what was termed as female pseudo-hermaphroditism. What does this mean? It means that in these patients, the genotype, that is, if you do a karyotype, they will be 46XX. So the first word female, look at the first word in the hermaphroditism term. If it is female, that means their actual genetic makeup is that of a female, 46XX, but their external appearance is that of a male. Okay, and the new term, now, the newer term what we use is DSD. So the new term for female pseudohermaphroditism will be 46XX DSD. Okay. Next, the previous term, male pseudohermaphroditism, means their genetic makeup will be 46XY. But when you look at them externally, they look like females. Okay. And the new term is called as 46XY DSD. Okay. What is true hermaphroditism? True hermaphroditism or people who has both ovaries and testes. So their chromosome will be 47XXY. Okay. And their phenotype will be a mixture of male and female like appearance. Okay. And again, in the newer system, they can be expressed as 47XXY DSD. Okay. Now, the newer concept is sex reversal. Somebody with a male chromosome might get converted to female, or a female might get converted to male. So when a genotypic male gets converted to female, that is somebody with 46XY, actually a male who gets converted to female, if you do a karyotype, obviously it will be 46XY, but their external appearance would have been changed to female by surgery. Okay, they will look like female and their genitalia will look like female. And these people are actually called as 46XY complete gonadal dysgenesis. Okay, this is the new term. This is the new term for somebody, a male who's underwent a sex reversal into female. Whereas a female, actual female who has undergone surgery to become a male into a karyotype, they will be females, but external appearance will be changed into male by surgery, and their external genitalia will also made to look like surgery. Now, these people are called 46XX testicular DSD. Okay, so these are the new terms that you should remember in people who have a different genotype and phenotype, that is people with hermaphroditism. All right. Now let's look at how to approach a patient with 46 DST. 46 DST means that their genotype is 46XX, okay, but their external appearance is that of a male. So they might have hirsutism or virilization, and they might have ambiguous genitalia on examination. It might not be a clear-cut male genitalia, but it will not be an exact female genitalia where there will be clitoris and labia and all that, okay. So somebody with 46XX DST, you have done a karyotype and you have confirmed that it is 46XX. The next test that you have to do is 17-hydroxyprogesterone. Okay, you do 17-hydroxyprogesterone, and if this comes as elevated level, it's a diagnostic test for congenital adrenal hyperplasia. Now, this is two type. One can present in the neonatal period and the adult in the adult period. If it presents in the neonatal period, it can be an emergency, but because it can cause electrolyte imbalance and they can present with ambiguous genitalia. Okay, so in congenital adrenal hyperplasia, there's a lot of corticosteroid produced that can get diverted into the androgen pathway and produces a lot of testosterone, and that is why there is virilization of the female. Okay, if the 17-hydroxyprogesterone level is normal, then there are three main causes. See if there is any drug intake by the patient, or if there is any enzyme deficiency, or if there are any tumors that are secreting androgens. In the drug, any progesterone intake, excessive progesterone intake during pregnancy can cause virilization of the mother as well as the female baby. Okay, or if by mistake she's taken any testosterone containing tablets, then it can cause virilization of the mother as well as the baby, a female baby. Okay, coming to enzyme deficiency, if there is a deficiency of aromatase enzyme, if aromatase enzyme is less, because aromatase enzyme is what converts testosterone into estrogen in the adipose tissue. Now, if this is not present, there will be increase in testosterone. It will not get converted into estrogen. So when there is increase in testosterone, it can cause virilizing features. Okay. Tumors are tumors that secretes increased testosterone. Now, this can be any ovarian tumor, and in pregnancy, especially, it is called luteoma. These are benign tumors, but they can cause increased testosterone, or they can be malignant in any age, like Sertoli cell tumor. These tumors or cause increased testosterone, or the source can be adrenal glands. Adrenal glands can also, if there is a carcinoma, they can produce increased testosterone and cause virilization. So the crux point is, anything that causes increased testosterone level in the body in a female can cause virilization and make them look like a male when they're actually females. The main pathological condition that you have to rule out is congenital adrenal hyperplasia, and the diagnostic test of choice for that is 17-hydroxyprogesterone. Now, how do you approach a patient with 46XY DST? These people are male pseudohermaphroditism. That means the karyotype is 46XY. They'll have testes, but they will look like a girl. There is under-virilization of the male body. So that means there is reduced testosterone in the body. There are three main causes. Again, it can be because of certain drugs. It can be because of deficiency of certain enzyme, or it can be some other congenital conditions. Okay, certain drugs that can cause decrease in testosterone level. First is called cyproterone acetate. These are commonly found in OCPs, some of the newer OCPs, and the mechanism of action is by reducing an enzyme, reducing the androgen receptor action at the receptor level. So testosterone is getting produced, but the receptors are not acting, so there is no external virilizing features. The other drug is called finasteride. This acts by reducing a hormone called 5-alpha reductase. What does 5-alpha reductase do? They convert normal testosterone into dihydrotestosterone. Dihydrotestosterone is the potent form of testosterone, and this is what finally acts on androgen receptors to cause virilizing features in a male, such as hair growth, increase in of genitalia, change in voice, and all that. Okay. So now, if this is absent, if this enzyme is absent, it will only be the impotent form, the normal testosterone, and there will be under-virilization. So in deficiency of enzyme, it is the same enzyme. When there is a reduced 5-alpha reductase because of some congenital abnormality, it can cause undervirilization. Other congenital causes are androgen insensitivity syndrome. In androgen insensitivity syndrome, there is testis, and the testis thus produce testosterone, but the receptors are faulty. The receptors are faulty. So receptors in the body, like the hair follicles, the external genitalia, and all that for testosterone is reduced. So there is no hair growth. Okay, so they'll have smooth skin like females, but this testosterone gets converted to estrogen because aromatase activity is present. So because of this estrogen, there will be breast development. All right, and the external genitalia appears like a vagina, that there will be no uterus formation because this testis produces Mullerian inhibiting substance that will make sure that the uterus is not formed, and they will have a blind vagina. So AIS is one condition. Androgen insensitivity syndrome is where the gonads will be testis, but the external appearance will be that of a female. Okay, now let's come back to the question. Congenital adrenal hyperplasia can lead to following presentation. So congenital adrenal hyperplasia, we saw that there is an increase in 17-hydroxyprogesterone, which leads to increased cortisone production, which eventually leads to increase in testosterone. So in a female, there is increased testosterone leading to appearance like a male. So that means the karyotype is 46XX, but since the appearance is different, we call this differentiation of sexual disorder. So the answer will be A. The old name for this will be female pseudohermaphroditism. Pseudo because it's only a false appearance. They are actually females by gonads, that is by chromosome, but they look like male. That's why it's called pseudohermaphroditism. Okay. The newer term is 46XX DST. 46XY or actual males who look like females. We saw the conditions. Ovotesticular DST or true hermaphrodites, and they will have 47XXY chromosome. External genitalia of female appearance. In congenital adrenal hyperplasia, there is virilization of the external genitalia in a female, so it will cause ambiguous genitalia appearance. We are not sure. There will not be a straightforward penis and scrotum. There will not be a straightforward clitoris and labia minora. It will be a mixture of both. So in CH, there can be ambiguous genitalia appearance. Okay, so that is the end of today's session. That was a discussion on brief approach on disorders of sexual differentiation. I hope that was useful, and we'll see tomorrow on a different MCQ topic. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today,
Good evening, everyone. When you're preparing for INICET, one of the most important topics from biochemistry is glycogen storage disease. And today we are going to discuss about glycogen storage disease. At the start, I would like to start with a case study. Pinky, 10-year-old girl who had a grossly enlarged abdomen, was brought to the pediatrician with complaints of weakness, sweating, and pallor, which disappeared on having food. While taking her past history, Pinky's mother told that her milestones of development were slow when compared to the other siblings. Physical examination revealed hepatomegaly. Her fasting blood sample showed the following findings. Fasting blood sugar 48 milligram per deciliter, pH 7.23, lactate 30 milligrams per deciliter, ketone bodies 6 milligram per deciliter, triacylglycerol 400 milligram per deciliter, uric acid 12 milligram per deciliter. What is Pinky probably suffering from? Before trying to answer this question, let's quickly revise through the glycogen storage diseases. What is glycogen? Glycogen is the storage form of glucose, often called as the animal starch. Now, it's a homopolysaccharide. It is has two types of bond present in it. In the linear chain, we have the alpha 1,4 linkages, and at the branching points, we have the alpha 1,6 linkages. Now, I'm going to show you a table which looks quite scary when you look at it, but I will try to simplify it for you. Firstly, what all things you should know. First, you should know the classification. Types 0 onwards, type 10 is there in the current classification, but usually most of the questions come from type 1 to 7. So we should know the names of this type 1 to 7. I will tell you a simple mnemonic which I personally used during when I was a student like you to remember this. The mnemonic goes like Vani Pompey conducted a men's hostel tour. Vani, V stands for von Gierke's disease. Pompey, P stands for Pompey's disease. Conducted, C stands for Curie's disease. A stands for Anderson's disease. Men's, M stands for McArdle's disease. Hostel, H stands for Herf's disease. Tour, T stands for Tharouy's disease. The next thing that you have to know is that type 1 to 7 are autosomal recessive, while type 8 is X-linked. Okay. The next thing that we have to know is the enzyme deficiency in each. Now, type 0, the enzyme deficiency is of glycogen synthase, which is the key enzyme for glycogenesis. For type 1A, that is von Gierke's disease, that is glucose 6-phosphate. Type 1 is divided into 1A, B, C, about which I will be talking soon. Right now, just remember von Gierke's disease, glucose 6-phosphatase. And glucose 6-phosphatase is not present in the muscles. It is present in the liver, and hence the organs affected are liver and kidney. Liver and kidney. Okay, Pompey's diseases affects all the organs, all organs. Okay, Curie's disease affects the liver and muscle. Anderson's affects the liver. McArdle's muscle. Herf's again liver, and Tharouy's muscle. All right. Answer the question. What you have to look at is few of the highlighting points, like increase in uric acid is very typical of von Gierke's disease. Cardiomegaly most severe glycogen disease, whereas von Gierke's is the most common glycogen storage disease. Okay, now let's talk a little bit about glycogen storage disease type 1. Type 1 is further divided 1A is the deficiency of glucose 6-phosphatase. This is easy to remember. But what you have to remember is this glucose 6-phosphatase is present in the smooth endoplasmic reticulum. It is present in the smooth endoplasmic reticulum. You require a translocase to transfer the glucose 6-phosphate to the smooth endoplasmic reticulum, where the further reaction takes place. A defect in that translocase causes type 1B, right? And when this translocation is taking place, inorganic phosphate has to be transported out of the endoplasmic reticulum. A defect in that transport of inorganic phosphate leads to type 1C. So having understood that, what are the typical features of type 1? Number 1, we have fasting hypoglycemia, which leads to ketosis and hyperlipidemia. Most commonly, increase in the triacylglycerol level is seen. Then there is hyperuricemia. What causes hyperuricemia? There is accumulation of glucose 6-phosphate. This glucose 6-phosphate is directed into the HMP sugars, pentophosphates. Am I audible? Are we still connected? Okay. Okay. So we have hyperuricemia. So coming back to our patient, Pinky's lab, before going to the Pinky's lab findings, quickly let's go through what are her clinical findings. She has weakness, sweating, and pallor, which disappears on having food, which means she has fasting hypoglycemia, delayed milestones of development, right? So let's analyze the lab values. Fasting blood sugar, ideally, the reference range is 70 to 100 milligram per deciliter. So she is definitely having hypoglycemia. pH, the normal pH is 7.38 to 7.42, right? So she is having acidosis. The lactate levels are 3 to 8 milligrams per deciliter normally. So there is accumulation of lactate. Ketone bodies, usually we have 2 to 3 milligrams per deciliter. Here it is 6 milligram per deciliter. So it is increased. Triethylglycerols is also increased. Uric acid is also increased. Thus, Pinky has von Gierke's disease. If we have understood this approach, I would like to highlight few more questions from the same topic. Why does patient with glycogen storage disorder type 1A present with gout? Now, gout is due to hyperuricemia. And what causes hyperuricemia in a patient with type 1 glycogen storage disease? Increased formation of pentosis. We have already seen that we have increased levels of glucose 6-phosphate, which is directed into HNP pathway, where pentose sugars are formed, which is directed to the purine synthesis, and thus we have increased formation of pentosis. Now, glucose 6-phosphate in the cytoplasm is not acted upon by glucose 6-phosphatase. Why? We know that the enzyme glucose 6-phosphatase is present in the smooth endoplasmic reticulum, and glucose 6-phosphate needs to be transported into the smooth endoplasmic reticulum. Okay, let's look at another question. A female infant developed signs of liver disease after 1 month of birth. She appeared to be normal at birth. After 3 months, she developed muscle weakness and severe hypoglycemia on waking up in the morning. Hepatomegaly was present on physical examination. Lab reports showed ketoacidosis, pH 7.2, increased AST and ALT, over 1000 international units per liter. Intravenous administration of glucagon followed by meals normalized blood glucose, but glucose level did not rise when glucagon was administered after overnight fast. Liver biopsy revealed glycogen constituted 8% of the bed weight. Which enzyme deficiency leads to such a clinical scenario? Now, on looking at first instance, we feel that this is very much like von Gierke's disease, but this is not von Gierke's disease. Okay, here the important thing that you have to remember is in von Gierke's disease, the enzyme defect is glucose 6-phosphatase. Thus, both gluconeogenesis as well as glycogenolysis is affected. But here we can see that on intravenous administration of glucagon followed by meals normalize the blood glucose. Thus, what it means is gluconeogenesis is still functioning. So here the defect is in the debranching enzyme, and what we are dealing with is Cury's disease. Now, few things about Cury's disease that we have to remember. It is the problem is in the debranching enzyme. What all things do we have to remember from debranching enzyme? We have to remember that it is a bifunctional enzyme. What are the two functions that it carries for? Number one, it is a alpha-1,4 transferase. And number two, it is alpha-1,6 glucosidase. That is, it causes hydrolysis and thus releasing free glucose. Okay, and one more additional point good to remember is what is the ratio of glucose 1-phosphate to glucose in glycogenolysis? It is 10:1. For every 10 glucose 1-phosphate, 1 free glucose is removed. Okay, in this situation, in Cury's disease, what you have to remember is there is gluconeogenesis is still active. Glycogenolysis is not active. It is not active at the branching points. At the branching points, it is not active. Okay. Now, the symptoms will be not as severe as von Gierke's disease. And one of the important things is transaminases will be elevated. Here in our patient, it is in the levels of 1000. Okay. Now, DASH acts as a cofactor for glycogen phosphorylase. Now, glycogen phosphorylase is the regulatory enzyme for glycogenolysis, and the coenzyme is pyridoxal phosphate. Now, from glycogen storage disease perspective, we have two diseases associated with glycogen phosphorylase. The muscle version, which is called as the McArdle's disease, and the liver or hepatic form, which is known as the HERS disease. Okay, and the coenzyme is pyridoxal phosphate. Do remember this. Lastly, the deficiency of which enzyme causes Pompe's disease. Now, acid maltase or alpha-1,4 glucosidase. Alpha-1,4 glucosidase is the enzyme whose deficiency is responsible for Pompe's disease. Few very important things to remember about Pompe's disease is that it affects in infancy. The patient usually dies by 2 years of age. And what leads to the death of the baby or the patient? It is due to the cardiac or respiratory failure. Cardiac or respiratory failure. Enzyme deficiency is acid maltase. And one of the very important thing that you have to remember is all the organs are affected in Pompe's disease. Okay. The last point which I would like to add here is enzyme replacement therapies have been started for glycogen storage disease, and it is being very well used in type 2, that is Pompe's disease, to treat Pompe's disease. Okay, so that's all for today. See you in the next class. Good night.
Good evening. In today's class, what we are going to see is disorders of pilosebaceous gland, and we'll discuss few MCQs related to it. First question: a 20-year-old female comes to the OPD with acne. So, what is the pathology of this acne? They are asking. Acne is due to disorder in the pilosebaceous gland. Next question: you have to say true or false. One second. So in this question, they're asking true or false. So acneiform eruption are polymorphic in nature. First, this is the first sentence. For this, you have to know what is acneiform eruption. Acneiform eruptions are nothing but they are the lesions which looks similar to acne, and they will be monomorphic in nature compared to the acne. In acne vulgaris only, what you see is polymorphic. The word polymorphic means lesions of different morphologies will be there. Papules, pustules, nodules, everything will be there. In case of acneiform eruptions, what you see is monomorphic eruptions. And so this is a false statement. First one, acne vulgaris can be associated with hirsutism and PCOS. This is true statement. Because of the hormonal imbalance, this can be associated with the other two conditions. Hirsutism is nothing but increase in the hair growth in the hair bearing areas, apart from the hair bearing areas in the male pattern hair growth. And third sentence, acne conglobata resolves on its own. So this one, acne conglobata is a severe form of acne. It won't resolve on its own. So this is a false statement. And the fourth sentence, before starting isotretinoin, UPT urine pregnancy test should be done to for starting isotretinoin, urine pregnancy test should be done for women of childbearing age. This is also a true statement. And so this is the answer for the question. So next question, what is the most common adverse effect of retinoids given for acne? So the most common side effects, all these are side effects of retinoids which is given for acne. Usually we give isotretinoin, teratogenicity, hepatitis, and hypertriglyceridemia, and cheilitis. Cheilitis is the most common side effect. Next one, which of this following syndrome is not associated with acne? Acne is associated with certain syndromes. Papa syndrome, PASH syndrome, Apert syndrome, and Sappho syndrome. So all this you should remember by heart it and remember it. These four syndromes: Papa syndrome, PASH, Apert, and Sappho syndrome. All of the above syndrome is associated with acne. And next MCQ, a 22-year-old female comes to you for treatment for her acne. She's having mild papulopustular acne. And what is the first line treatment of such patient? So acne treatment for acne. Actually, you can divide into comedonal acne. First, First, we'll see a little about acne, then we'll come to treatment. Acne is the chronic inflammatory disease of the pilosebaceous gland. It affects mainly the areas present in areas where the pilosebaceous glands are present in the larger quantities. So it is mainly in face and neck and upper trunk. And usually, as I told, it causes polymorphic eruption. We can see papules, pustules, nodules, scars, and comedones, and it is associated with other disorders of hormonal imbalance, such as PCOS, hirsutism, and hormonal imbalance. The pathogenesis of acne is mainly due to the hormonal imbalance, and it causes hyperkeratosis of the pilosebaceous hair follicle and blockage of the blockage of the hair follicle, leading to acne. So in case of acne, what you in case of acne, what you can see is blackheads, which is called as open comedones, whiteheads, papules, pustules, cystic and nodules, cystic lesions and nodules. And what you can see here is a pustule, and the smaller lesions is a papule and nodule. So syndromes associated with acne. This is, as I told earlier, you should remember this main four syndromes: Papa syndrome, PASH syndrome, PASH syndrome, and Sappho syndrome. Acneiform eruptions. This is due to mainly due to drugs, such as main drugs which causes acneiform eruption is anabolic steroids, anticonvulsants. ATT drugs are the most. These three are the most common drugs which commonly causes acneiform eruptions, and this causes monomorphic lesions, only papules on trunk, and it is not associated with comedones. So this is like this. Unlike acne, acne causes polymorphic eruptions, as I told earlier. Then acne conglobata is the severe form of acne with papules, pustules, tender nodules, and abscesses. And it will be associated with interconnecting sinuses also and grouped comedones. And the treatment for this acne conglobata is you give systemic steroids along with isotretinoin. Acne fulminans. This is also a severe variant of acne. It's a very inflammatory variant. It's associated with tender nodules, ulcerative form of acne, and hemorrhagic crust. And triggers for this acne fulminans is oral isotretinoin itself. If you give for acne, it can trigger acne fulminans, and anabolic steroid, and associated with systemic symptoms. Acne excoriae. Patient picking. This is a special type of acne. If you pick the acne, it leads to scarring and pigmentation. Treatment of acne. Acne can be divided into comedonal acne, mild papulopustular, and severe acne. In case of comedonal acne, mainly you give topical retinoid as the treatment, as a first line treatment. As a second line treatment, also you can give azelaic acid. So no role for any other drug in case of comedonal acne. In mild to moderate papulopustular acne. As a first line treatment, you can give fixed dose combination of topical agents. Your topical agents used for mild papulopustular acne is clindamycin. You can adapalene, benzoyl peroxide. This is what they had given in this. You should give always given fixed dose combination format. In second line, you can start with oral antibiotics, systemic antibiotics. Mainly what we give is tetracyclines, doxycycline and minocycline is given. If the patient is having hormonal imbalance, then you can start the patient also on combined oral contraceptives. Second line treatment, apart from this, you can give topicals along with oral antibiotics and along with other therapies, supplementary therapies such as blue light and oral zinc can also be given for next line treatment of mild papulopustular acne. In case of severe acne, what you have to remember is only this. In case of severe acne, actually there is no role for any topical treatment. You can consider oral isotretinoin monotherapy early in the course to avoid severe flash of acne or acne conglobata or acne fulminans. So this is all about treatment of acne. And in case of severe acne, what you give is retinoid. That the retinoid which we give in case of severe acne is isotretinoin. The most common adverse effects of isotretinoin is cheilitis, most common is cheilitis, retinoid dermatitis, hyperlipidemia, hepatitis, and teratogenicity. So this is all about acne. Next question: a 40-year-old female having multiple erythematous papulopustular lesions on convexities of face. There is background of erythema and telangiectasia. What is the most likely diagnosis? So here the key point is papulopustular lesions are also there, and background erythema and telangiectasia is there. So if they had given only erythema and telangiectasia, then you could have thought about this SLE rash or malar rash. If they had given only papulopustular lesions, then you could have thought of acne vulgaris. So combine these two, papulopustular lesions within the background of erythema and telangiectasia mainly occurs in case of rosacea. So let's discuss rosacea. Mainly affects face in the sun exposed areas only. There are many trigger factors for rosacea. Sun exposure, taking hot liquids, spicy foods, alcohol, emotional disturbance, and exercise. And the etiology is supposed to be like it is thought to be, there is a hypothesis that Demodex folliculorum might is involved in the pathogenesis causation of rosacea. And types, there are four types of rosacea. First one is erythemotelangiectatic type. It is associated with erythema and telangiectasia. Papulopustular rosacea, which is associated mainly will have papules and pustules. In the fibrous form, you have sebaceous hypertrophy, which is associated with, which is also called as potato nose. And in ocular rosacea, you have ocular blepharitis and findings around the eye. And you cannot give topical steroids in case of rosacea. So this is the case of rosacea. Next question: Miliaria rubra vera. This is due to obstruction of which gland? This is due to obstruction of sweat gland. So in Miliaria rubra, what happens is obstruction happens in the eccrine sweat glands, and it leads to reduction of sweat. It leads to accumulation of secretions inside this, and this also has the causative agent. It is thought to be staph epidermis, which plays an important role in the pathogenesis of Miliaria rubra. This Miliaria rubra has three types: Miliaria crystallina and Miliaria rubra and Miliaria profunda. Crystallina is a superficial form where you will find crystal-like lesions, obstruction at the level of stratum corneum, and Miliaria rubra is the second one, which is the most common. As the name indicates, rubra means red, so you'll have red itchy papules, and here the obstruction is at the level of spinous layer. So here very superficial, stratum corneum. Here at the mid-level, spinous layer. Miliaria profunda is associated with flesh-colored papules. Here the obstruction is at the deeper level, in the upper dermis and the dermoepidermal junction. So this is Miliaria crystallina. So I'll wind up the session with this question. Rest of the questions we'll discuss tomorrow. Thank you for the session.
All right. Right. So welcome to our anesthesia discussion today, and I want to do something new and something different for you. And in this particular question, I'm giving you two questions. One question which could come for you from an image-based ECG aspect question, and that ECG linked to anesthesia. So this is what we are trying to do today. I'm linking ECG and anesthesia. And this particular topic, if you want to understand from anesthesia point of view, it comes under preoperative evaluation of the patient. Okay. Now, let me just read out the question for you. It is an extremely important and ECG very significant. Okay, sorry. So again, let me take you back to this question. A 30-year-old man is diagnosed with appendicitis and is planned for appendectomy under general anesthesia. As a part of routine evaluation, patient's ECG was taken and it is given below. The patient also gives a history of a syncopal attack few months back for which he did not take any medical consultation. What drug will the anesthesiologist not use as a part of anesthesia plan in this patient? Okay. So if you want to know what drug you're not going to use, obviously we need to diagnose the condition, and this ECG is a quite classic ECG of a very particular condition. Okay. The options that are given for you are propofol, succinylcholine, ketamine, vecuronium, oral drugs which are used in general anesthesia. Right. So let me take you to this particular question and make you understand this ECG and diagnose this ECG. In this ECG, what I want you to look at is these three important leads, V1, V2, and V3. So when you're looking at V1, V2, and V3, what are you seeing? You are seeing a right bundle branch block pattern. Along with that, you are seeing an ST elevation pattern like this. Okay. So if you look here also, you're seeing an M pattern or right bundle branch block pattern associated with ST elevation. So you are seeing RBB pattern in V1, V2, V3, which is associated with ST elevation, right? Now I'll make you understand why this is right bundle branch block pattern, and you'll understand the concept of right bundle branch in your ECG as well. But what you're essentially seeing here is right bundle branch block pattern along with ST elevation pattern in V1, V2, and V3. So if you are getting a right bundle branch block pattern along with ST elevation in these three leads, the diagnosis that you have is something which is called as Brugada syndrome. Okay, Brugada syndrome. And please do understand that Brugada syndrome is one cause of sudden cardiac arrest and death. It predisposes the patient to ventricular fibrillation and ventricular tachycardia, and it predisposes the patient to sudden cardiac death. So that is what you need to understand. It is a syndrome which predisposes the patient to sudden cardiac death. So it is a cardiac condition, and the patient is prone for sudden cardiac death. And if you're an anesthesiologist, this finding is often very incidental because most of the people will be young, healthy people, and they will not be having any previous history which is suggestive of a cardiac condition. So you might think that the patient is absolutely normal, and you will post the patient for surgery, and you will give the patient general anesthesia as per the routine norms, and sometimes it can lead to sudden cardiac death of the patient in the intraoperative period. That is the significance of understanding about Brugada. And if you are identifying Brugada syndrome in your preoperative evaluation, obviously you still have to proceed with the surgery. But when you are proceeding with the surgery, you will avoid two important things. One is propofol, the other drug is bupivacaine. So these two drugs are something that you are going to avoid in your anesthesia plan when the patient is having Brugada syndrome, because both these drugs are cardiotoxic, and both these drugs can precipitate ventricular fibrillation in a patient with Brugada syndrome. Obviously, the only treatment option which can prevent sudden cardiac death in this patient is implantable cardiac defibrillator. Okay, so if you want to save this patient, you need to place an automated implantable cardiac defibrillator in the patient. That is there, you know the condition. The diagnosis is Brugada syndrome, and the drugs that you will avoid in Brugada syndrome is propofol and bupivacaine. If you want to treat Brugada syndrome per se, you are going to place an implantable ICD. Right, so that is what you are going to do. Now let me make you understand why this pattern called as RSR pattern is suggestive of right bundle branch block. Now many of you students might have mugged up how it looks like. I'm just going to make you understand the concept of this particular right bundle branch block. Okay, now let me just draw a heart here. Okay, so let me just draw a heart here, right? right? This is your heart normally, and this is your intraventricular septum. Okay, this is your interventricular septum. Now let me talk about ventricular depolarization. You know that there is something which is called as bundle of His, and bundle of His divides into a right bundle and a left bundle. The left bundle gives off a very, very small septal branch which causes septal depolarization. The direction of septal depolarization is from left side to right side. Once septal depolarization is done, obviously ventricular muscle mass depolarization is going to happen. The right bundle along with Purkinje fibers is going to cause right ventricular depolarization. The left bundle along with Purkinje fibers is going to cause left ventricular depolarization. The right ventricular depolarization proceeds from left side to right side, whereas your left ventricular depolarization proceeds from right side to left side or towards the left side. Now, if you are V1, imagine that you are lead V1. Remember that any lead, if an electrical activity is happening towards you, it produces a positive deflection. If electrical activity happens against you, it produces a negative deflection. Now, V1 is a lead which is placed on the right side of your septum. Okay, and V6 is a lead which is generally placed on the left aspect or lateral aspect of your left ventricle. Now, if you are V1, generally what is going to happen? The first depolarization activity is septal depolarization, and septal depolarization generally proceeds from left side to right side. And because it proceeds from left side to right side, or because it's proceeding towards your V1, it produces a small positive deflection. And after that, what is going to happen? Your right ventricular depolarization and left ventricular depolarization is going to happen. But because your left ventricular muscle mass is generally more, if you take the average electrical vector, it will be inclined towards the left. Or in other words, it is inclined to go against your V1. So because your general or electrical vector of ventricular depolarization is going towards the left, if you look at V1, after the initial small positive deflection, you are going to get a significant negative deflection like this. Remember, the first positive deflection of your V1 is what is called as R. And because this is small in amplitude, I'm going to call it as small r. And the S, the negative deflection which follows the R wave is what is called as S wave. And that is here called as S. So the general complex that you expect in V1 is small r capital S. And if you look at V6, the exact opposite is going to happen. A predominant vector is going to come towards V6, which is indicative of cumulative ventricular depolarization. So what am I going to get in V6? I'm going to get a very significantly positive deflection in V6. Followed by that, I'm going to get a small negative deflection. This negative deflection that I'm getting here is the reciprocal change to what I'm getting in V1. So this is a normal morphology of V1 to V6. Please do remember that the R wave height gradually increases from V1 to V6. It is very, very small, less than 4 millimeter in V1. And when it reaches V6, it attains a height of around at least 25 millimeter. This normal progression is what is called as normal R wave progression. In conditions like chronic lung diseases, in conditions like old anterior wall MI, you are going to have a poor R wave progression. In the sense, your V6 can look like this, where your R wave height has not achieved and the S wave has not disappeared significantly. This is poor R wave progression seen in chronic lung diseases and old anterior wall MIs. Now that is not our point. We are trying to understand about right bundle branch block pattern here, right? So right bundle branch block means you are going to have a block here. You are going to have a block here. Now imagine the sequence of events which are going to happen. Now imagine that you are V1. Okay, imagine that you are V1. Obviously, the first activity is septal depolarization. And remember, septal depolarization is done by a branch of left bundle branch block. And because it is absolutely normal, there is going to be no difference in septal depolarization. So the first activity is again going to be septal depolarization, which proceeds from left side to right side. So you are going to get a small positive deflection. Now, post this, there is going to be some change. We know that the right bundle is blocked. So there is going to be uncoupling of ventricular depolarization. First, the ventricle that is going to be depolarized in right bundle branch block is obviously your left ventricle, because your left bundle branch is absolutely normal. So the left bundle is going to cause left ventricular depolarization. So left ventricular depolarization is something that is going to happen towards the left side of your heart, which means it is something which is going to happen against your V1, right? So because it is going to happen against your V1, it is going to produce a negative deflection. The story is the same till now, right? Now what happens is, After this negative deflection, imagine that your left ventricle is getting depolarized like this. Now, when you are saying right bundle branch block, it does not mean that your right ventricle is not going to get depolarized at all. What it means that it is not going to be depolarized by your right bundle branch. So after your left ventricle left ventricular myocardium get depolarized with your left bundle branch, this myocardial conduction itself is going to cause depolarization of your right ventricle. So what I mean to say is the right ventricle is going to be depolarized, but only after a slight delay. So there is uncoupling of right ventricular and left ventricular depolarization. So after left ventricular depolarization, your right ventricle is also going to be depolarized. So it is going to be depolarized after some time, but it doesn't matter. Right ventricular depolarization is obviously going to produce a positive deflection in your particular V1. So your V1 is going to look like this. So if I want to just refine that image, it is going to just look like this. If I want to call it a pattern, this is small r, this is capital S, this is again an R, which is a prominent R, and this is a capital R. But because it is a second R, I'm going to put this R prime or RSR dash. This RSR dash is what you generally are going to get in your particular V1 in right bundle branch block. And this is essentially how you identify right bundle branch block. Now, when you are having this particular right bundle branch block pattern, what is going to happen to the ST segment? Generally, please do remember that any condition which alters the morphology of your QRS complex, may that be in terms of amplitude, may that be in terms of width, it is going to cause a secondary STT change, which is generally ST depression, T wave inversion. So if you look at V1 generally in your right bundle branch block, you are going to get this RSR pattern, which is associated with a T wave inversion and ST depression. This is normal of your right bundle branch block. Okay, this is what you expect in a right bundle branch block. Imagine you are getting this right bundle branch block in V1, V2, and V3. And instead of the secondary STT change, you are getting an ST elevation, which is called as a false ST elevation, where your image is going to look like this. Then it is called as Brugada syndrome. It is a very, very specific ECG diagnosis. The only thing the patient sometimes might give you is that the patient might be having a history of syncope sometimes before, for which the patient might not have taken any medical consultation, etc., etc. So when you are finding this particular finding in your ECG, it is called as Brugada syndrome. And when you are getting Brugada syndrome as a clinical finding, please do remember that that is one cause of sudden cardiac death. Many football players might have also got Brugada syndrome, which could have been the reason for their sudden cardiac death in their football playing field. Okay, so when you are getting Brugada syndrome, as an anesthesiologist, what are you going to do? You are going to prevent the patient from taking propofol, or prevent the patient from being given with bupivacaine. But if you are a physiologist, if you are someone who's expecting a question from ECG from a medical aspect of point of view, please do remember that the treatment of choice for Brugada syndrome is something which is called as implantable cardiac defibrillator. Okay, now this is the ECG. Please do remember this particular pattern, right bundle branch pattern associated with an ST